Good afternoon, everyone.
Good afternoon, Madam Chair.
Thank you. Welcome to Senate Finance. Today is Tuesday, February 7th, 2023. We have 10 bills that we'll be considering today in the following order. Senate Bill 168, Senator Gazzone. Senate Bill 231, Vital. Senate Bill 154, again, Senator Vital. Senate Bill 145, Senator West. Senate Bill 187, which is Senator Kagan. Senate Bill 201, Senators Hester and Augustine. Senate Bills 161, 188, and 200 are Senator Lamb's. And then Senate Bill 232, Senator Vital. We are going to begin, colleagues, with a bill from our good friend, the chair of the Senate Budget and Tax Committee, Senator Gazzone, who's presenting Maryland Developmental Disabilities Council establishment. You're welcome to bring your panel up forward, Mr. Chair. You know the drill. It's always good to see you.
It is really great to see you sitting up there. So good afternoon, everyone. This should be pretty simple and quick and easy. There are a lot of groups out there. This committee is used to hearing from advocates for developmental disabilities, MACs and people on the go, and all kinds of folks come out. But there's one entity out there that actually is one that was created by the federal government, and it's the Developmental Disabilities Council. And every state has one, and they're supposed to be independent bodies that provide advocacy and do work on policy. And so it turns out that for years, this council has been embedded in our Department of Disabilities, and it really should be outside of that. And it's been functioning that way as an independent entity, but this is really just a cleanup bill to make it such that it would be that independent part of government outside of any other part of state government. And that's what it does.
Madam Chair, Madam Vice Chair, I'm Rachel London. I'm the Executive Director of the Maryland Developmental Disabilities Council. And we are a public policy, totally independent, that creates change to make it possible for people with developmental disabilities to live the lives they want with the support they need. We do that in two big ways. Advocacy, which Senator Gazzone has already mentioned. We also do that with grant funding. And with a very, very small team. Two of my staff are here with us today, along with our council chair. Just in terms of a little bit of background, federal law about people with developmental disabilities dates back to the early 1960s. In fact, the first piece of federal legislation that talks about a designated state entity around developmental disabilities was from 1963. And then in 1970, it was updated, and the Congress passed a precursor for what we now know as the Developmental Disabilities Act. That is the act, the federal law, most recently updated in 2000, that mandates all of the DD Council's operations. So in Maryland, in 1971, the then governor created the State Planning Council on Developmental Disabilities by executive order. Again, now we're known as the Maryland Developmental Disabilities Council. So we've had a few iterations. We were at the Department of Health for a while. And then in 1987, they updated the executive order and put us within the governor's office for individuals with disabilities, now the Department of Disabilities. The executive order has not been updated since. And yet we are operating and get our mandates from a law that was updated in 2000. A couple of things. We're still co-located with the Department of Disabilities, but we're completely independent. In fact, that federal law says we have to be, right? And so what this bill does is update that very, very old executive order with more current language. It moves the council into being an independent state agency. does not change how we operate. It does not change the fact that we will continue to advocate and use our 100% federal funding to change lives and improve services and supports for people with developmental disabilities. Thank you.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Carol Beatty, and I am the Secretary for the Maryland Department of Disabilities. And I want to thank you for allowing me to testify today in support of this bill. You also should have a letter of support that the department has provided. The Developmental Disabilities Council is co-located with our department in Baltimore, but operates wholly independently from us. Their funding is 100% federal funds from the U.S. Department of Health and Human Services, the Administration on Community Living. Their mission, activities, and operations are determined by the DD Act, and the Maryland Developmental Disability Council reports directly to ACO. That being said, the Department of Disabilities partners in numerous ways with the DD Council on many issues and projects that are important to Marylanders with disabilities and benefits them directly. I can give you lots and lots of examples. I think one that comes to mind is our work together during the COVID pandemic and how we worked so that people with developmental disabilities, as well as the staff that support them and their families, had access to all the things that were necessary to keep them safe in their homes and in the community. We also recently have partnered to expand the availability of accessible and inclusive playgrounds across the state. And we have a work group that we jointly chair, developing best practices for local municipalities, counties, and private entities. We hope to make available very shortly a toolkit for planning, obtaining funding, and creating these inclusive places and spaces appropriate for all ages. Preserving our very effective partnership with the DD Council is very important to the work of the Department of Disabilities. This bill will not impact on any of our current and future work together. It simply codifies the existing operations of the DD Council. I urge the committee's approval of Senate Bill 168. Thank you.
Thank you. Are there any questions for the sponsor or the panel? Seeing none, thank you so much for your testimony, Mr. Chairman. We know you have a lot of work to do. Thank you for your presentation. And I should have said at the outset to everyone, we have now, I think, 85 or so witnesses to go today. And so you'll see a timer when you come up to testify if you're signed up as a witness, and there are 2 minutes for your testimony if you're not the sponsor of the bill. In addition, we will have some virtual witnesses on some of the bills, and so members will just take those as they are scheduled on our witness list. With that, we're going to move to Andy Culp and Elizabeth Hall, if you're here testifying in favor of the bill. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Andy Culp, and I'm here on behalf of the ARC Maryland. I'm the Executive Director of the ARC Maryland, and we provided written testimony, the ARC and MACS, which is the Maryland Association of Community Services, together in support of this bill. Some really important points were made, and I know you have a busy day, so I'll just emphasize one, and that's that you may know that Maryland, ARC, and MACS are members of the DD Coalition, along with the DD Council and People on the Go of Maryland and Disability Rights Maryland. We've always appreciated our autonomy and independence from state government because ultimately we're acting on behalf of people with developmental disabilities, our workforce and their families. And so sometimes our views may not always align with government. So our independence is really important. And, it falls in with a DD Council's mandate from the federal government that they need to be independent from the federal government. So I think this placement away from the Maryland Department of Disabilities is appropriate at this time. And we respectfully ask for your favorable report on this bill. Thank you. Sorry about that.
Thank you very much. I thought you had a 1-minute timer on your watch. Thank you for your testimony. I don't see any questions from the committee, so thank you very much.
Okay, thank you.
Is Elizabeth Hall? Oh, very good. Good afternoon.
Hi, this is just a clarification. I'm the legislative liaison for the Department of Disabilities. So that was on behalf of the secretary. So she's already given her, so see, in under a minute.
There you go. Thank you very much. There's a bunch of questions for you. No, thank you so much. I don't see any questions from the committee, so that will conclude the hearing on Senate Bill 168. Colleagues, we're going to move to Senate Bill 231. Senator Beidle is going to present the Maryland Medical Assistance Program Autism Waiver Military Families. Good afternoon, colleague.
Good afternoon, Madam Chair, members of the, and Madam Vice Chair and members of the committee. Thank you for hearing Senate Bill 231. For the record, I'm Senator Pam Beidle representing District 32. This is a very easy bill. District 32 includes Fort Meade, so that's really drew my attention to this bill, but families get on the list for the autism waiver, and it can take years to get to the list where they start receive services. But if you're in the military and you get transferred to another base and then come back to Fort Meade, which happens frequently because we're a compassionate base, and also with cyber, you could go to another cyber installation and then come back to work at NSA or Fort Meade or one of the 103 facilities that we have at Fort Meade. So all this says is if you're on the registry and you move out of state and come back, you get to keep your place on the registry. So if you've come to the top, you don't get removed. It's just wait till you come back to the state and you'll receive your services. So just a little benefit for our military families.
Okay, see no questions for the sponsor. Thank you very much.
Thank you.
We have Rachel London signed up in support of the bill. Good afternoon again.
Good afternoon. For the record, Rachel London with the Maryland Developmental Disabilities Council. Just want to add a few more statistics in there. You have written testimony that is jointly from the council and the ARC Maryland, Andy Culp, who you just heard from. So there are about 6,300 children and their families waiting for autism services in Maryland. And we know that the benefits of early intervention, especially for young children with autism, is really critical. Yet, as you've heard, many children wait and wait and wait. In fact, they age out before they even receive services. And I've learned a lot from my partners in the military world and the Maryland Military Coalition about the issues for Maryland's military families and veterans through the work with the governor's transition team. And so I know that there are almost 50,000 active duty and reserve members in Maryland, many of whom have kids with disabilities because they do in fact move to Maryland. What we also know is that Maryland already provides for other people with disabilities to stay either on a waiting list or if they're become eligible when they're out for military service, out of the state for military service, space is reserved for them. The Developmental Disabilities Administration, in fact, the Developmental Disabilities Waivers reserve space for those in military service who move in and out. So this is possible and should be done for our military families across all of Maryland. And something all of the advisory councils and commissions that are looking at issues on autism are also looking into and have continuously discussed how to make sure people receive the services and supports. Thank you, Madam Chair.
Thank you. I've got the vice chair and then Senator Ellis. I'm talking.
Now, how many children are on the spectrum? You said it and I just missed the number.
So the numbers I know are that 6,300 children are on the registry
registry, that's what I
waiting
mean.
for services. 1,500 are in fact receiving services through the autism waiver.
Okay, so 6,300 or, okay, thank you.
Thank you, Senator Ellis.
Thank you, Madam Chair, and thank you, Senator Beidle, for this bill, looking out for military members. I have a quick question. So if you have a number of children who are on top of the waiting list and they are out of state, will those children displace others down below while they remain on the top? Will those slots remain open or will they be the services provided to others? And how does that work? Will they say, well, we have these slots open and let's not put any other children in the slots reserved for the military members?
Is there a great question? The way I read the bill, though, I would defer to Senator Bidle, is that they will, if their number comes up on the registry and they are in fact eligible. So not every child on the registry will necessarily be eligible for waiver services. It's a little bit different than other waivers where you go on a waiting list because you know you're eligible. These children, you can put any child's name on the waiting list. So, as soon as they're diagnosed so we don't know that every single child is actually eligible. If they are found eligible and outside of this state, then the way I read the legislation, is they will remain eligible and be able to receive services upon return, not that someone else is going to lose services or get pushed down in a reserved capacity way. But I will defer to the sponsor.
Senator Bidle.
Thank you, Madam Chair. And thank you for your testimony. And yeah, I don't know. But thank you. And I believe you're correct. It's not that another child's pushed out of the way, but when they come back to the state, then services will be provided.
Thank you. Any additional questions for this witness or the sponsor? All right, thank you very much. Thanks for your testimony.
Thank you.
That, colleagues, concludes the hearing on Senate Bill 231. We'll now turn to Senate Bill 154. And this is Senator Bidle presenting Public Health, Mental Health Advanced Directives, Awareness, and Statewide Database.
Thank you again, Madam Chair, Madam Vice Chair, and members of the committee. For the record, Senator Pam Bidle, District 32. So Senate Bill 154 was actually presented last year from Senator Eckert, and she asked that I reintroduce the bill this year. So the bill actually provides or requires that the Department of Health will develop and implement a public awareness campaign to encourage the use of mental health advanced directives. It also requires the Behavioral Health Administration to study the feasibility and cost of establishing a centralized statewide database of mental health advanced directives. So last year, the bill was Senate Bill 9994. It was passed in the Senate 44-0. However, it was not enough time for it to pass to the House. So I respectfully request a favorable report on Senate Bill 154.
Thank you very much. I see no questions for the sponsor. So we'll move to Margot Quinlan, Dan Rabbit, and Michelle Livshin. Probably something close to that. My apologies. Good afternoon. Good to see you both again.
Great. Thank you, Madam Chair, Vice Chair, members of the committee. My name is Margot Quinlan with the Mental Health Association of Maryland. We're here in support of this bill. Want to thank Senator Bidle for bringing this back and Senator Eckert for her leadership on this bill last year. So as was mentioned, a mental health advance directive is a legal document that allows a person with a mental illness to state their wishes and preferences in advance of a mental health crisis. These documents provide for more patient-centered care and can help resolve crises more quickly, appropriately, and without coercion. They allow individuals to clarify treatment preferences and crisis planning and often include and involve family members and social support networks. They can include specific wishes regarding treatment, preferred hospitals and service providers, persons authorized to make health decisions and with whom information may be shared, and others. And we really see these as a key piece in honoring the autonomy and dignity of people with mental health challenges, many of whom are older adults that may have long-term mental health challenges, but also folks across the lifespan can use these tools too. And so we think they're really important. And the sort of awareness campaign that's in this bill is uniquely important to lift up the need for and use of mental health advanced directives. So thank you again to the Senator for your leadership on this, and we're in strong support of this. Thank you.
Good afternoon, everyone. Madam Chair, Madam Vice Chair. For the record, my name is Dan Rabbit. I'm with Behavioral Health System Baltimore. We are the local behavioral health authority in Baltimore City, an independent nonprofit, and engaged in a lot of reforms around the crisis response system. We are also in strong support of SB 154. We see this as an important component to an effective crisis response system. When people are seeking help during a crisis, they may not be able to direct their own care. And so setting up a mental health advance directive, when they are able to think about what medications have worked well for them, what institutions have worked well for them, what institutions have not worked well for them, being able to set that in place so that that can be followed in the event that they are under duress and unable to direct their own care somewhere down the line is really important to having an effective crisis response system. It's also really helpful in building rapport and a alliance with your treatment provider to sit down and think about like what would you want to have happen in the event that you have a mental health crisis. So we think that this is an important component to making sure that people are safe when they do experience serious distress with living with a mental health disorder. The issue is that very few people know about these plans. They're not widely used. And then very few first responders are aware if someone has a plan such as this. So the promotional campaign is really important to get the word out to people living with mental health challenges, and studying how to create a database that could be accessed by hospitals, first responders, law enforcement, mobile crisis teams is also an important component. So we stand in strong support and urge a favorable report. Thank you.
Thank you. I don't see any questions. So, Senator Ellis, sorry.
Yeah. Thank you, Madam Chair, and thank you, Senator, for this bill. Thank you for your testimony. So I'm thinking about this database. Okay, it's well used. This bill calls for the advertising of this. So this database already exists, and or
No, it's uncodified language to direct the department to study it, to figure out what would it cost, what kind of privacy safeguards need to be put in place, how would it be accessed by providers. So there's a lot of questions in terms of how to set up a database.
okay.
And so I think it's appropriate to look into it more before creating such a thing.
So it's beyond awareness, but to study and to create the database.
Mhm.
And okay, thank you.
Sure.
Thank you, Senator. Any additional questions? Going once. Okay, I see no additional questions. Thank you very much. Have a good
Thank you, Madam Chair.
afternoon. I'm going to call one more time, Michelle Livshin. There you are. Good afternoon, and you can proceed.
Thank you, Chair Griffith, Vice Chair Klausmeier, and committee members for your dedicated service. I'm Michelle Livshin, Director of Network and Peer Empowerment of Honor Roan of Maryland. We are a peer-operated behavioral health education and advocacy organization representing a statewide network of peer support recovery services, providing free support to more than 6,000 individuals each year. We're in strong support of Senate Bill 154. In Maryland, individuals have the right to influence their mental health treatment decisions through the process of creating a mental health advance directive. These critical documents include important medical history, specific guidance on acceptance and refusal of certain types of treatment, including medication and modalities, and appointment of healthcare agent to legally make treatment decisions on their behalf. Unfortunately, there are significant current barriers to effectively and efficiently completing and utilizing mental health advance directives. Even amongst service providers, there is a lack of awareness surrounding the requirements for appropriate use or even access to these vital documents. In Maryland, there is currently no centralized or standardized process for making these documents available to any relevant treatment provider who may be involved in responding to a mental health related emergency. Instead, contact must somehow be made with a loved one or another provider in possession of the mental health advance directive. This lack of ready access means these documents are more likely to be ignored, or critical time and resources may be lost in the attempt to obtain the mental health advance directive, which is particularly concerning in time-sensitive and emergency circumstances. We support the proposal for the administration to create a public awareness campaign and study the implementation of a statewide database. We strongly recommend diverse stakeholder involvement in the study, particularly inclusion of those with lived experience of a mental health crisis. Mental health advance directives help to protect individuals' safety, honor their choices, and avoid preventable harm and trauma. Maintaining autonomy, safety, and trust is critically important for an individual's recovery from a mental health crisis. We urge you to vote in favor of Senate Bill 154. Thank you.
Thank you. I don't see any questions, so thank you very much for your testimony. Colleagues, we're going to modify our schedule a little bit and go to Senate Bill 187. The Vice Chair of E33E is here, and she's going to present health occupations, licenses, certificates, and registrations. Immigrants. Good afternoon, Madam Vice Chair. If you have a panel, you can feel free to bring them forward.
Thank you. Panelists, if you want to come on up. So for the record, Madam Chair, I call it E-Quad just to be different.
I know.
Education, energy, the environment, and elections.
I know.
So that's just me being me here. It's great to be in finance. I always come and visit you often and appreciate all the great work, and congratulations to the wonderful new chair and vice chair. For the record, I'm Cheryl Kagan, very proud to be the senator for Gaithersburg and Rockville. I am hoping that that despite the number of witnesses, that we're going to be succinct and briefer than the committee might anticipate, but we surely want to make sure that you have enough information. And for those who weren't on this committee or are new to the Senate, this bill came out of my old committee last year. So there are two folks who may remember it, and it did come to the Senate floor and pass out of the Senate last year. And it is a bill to address our crisis in healthcare personnel. The Baltimore Banner, you might have seen recently, published a study that showed Maryland shockingly rated 50th, dead last in emergency waiting time, an average of 228 minutes. And there's a story of a woman who waited on a gurney for 10 hours, which is insane. And the reason for that is we don't have enough personnel. So this is not a pandemic problem. This isn't something that was a little glitch. We go back in these issues and these challenges several years before the pandemic, and they're not getting better. So the question is, how do we address it? And there are not a lot of great ideas, but this is one way that we can start to solve it. And 14 other states have already taken this action, and that is not to require citizenship for people who want to work in Maryland as a healthcare provider. So when we think about DACA students or dreamers, they grew up here. They came maybe with their family. They went K through 12 in our public school, and we paid for their education. Then they might have gone to school in-state. We gave them in-state tuition. We gave them senatorial scholarships. And now that they are qualified and educated and ready to start their career, we slam the door in their faces and we say, go elsewhere. We don't want you. And so they go and they start their careers, they start their families, and they pay taxes in one of the other 14 states that is welcoming them. In the meantime, we have huge nursing shortages, thousands. The Maryland Hospital Association is among those that's going to be sharing their data. And so whether we're talking about dentists, nurses, nurse practitioners, behavioral health professionals, we have a problem. We are also talking about folks paying surcharges, surpluses, maybe going through contractors rather than actually hiring people. There is a risk with a liability that could happen without somebody who is actually vetted and on your staff. So, and they also would be paying them at a higher rate. There are a lot of places where healthcare professionals come from other countries and they want to serve in Maryland, and they have to do this enormous workaround and start in New Jersey or Florida or California, work there for a while, and then sort of come on loan to Maryland. And I've got experts who can explain that that craziness better than I can, but they shouldn't have to do that. They should want to come to Maryland or stay in Maryland and serve and provide health care to our residents. So this is basically Senate Bill 187 as the bill last year. It just says that healthcare professionals who are qualified, who have the training, the educational and the professional requirements, can practice here regardless of immigration status. It brings us ethnic and linguistic diversity, which is a bonus, and it allows the use of the ITIN as an alternative to the Social Security number. And ITIN is the, Senator Ellis, my friend on acronyms here, is the individual tax identification number. So that's an alternative. I just want to close with two things. One is I want to give you the list of states that have already enacted this. And I want you to notice that they are neither all liberal or conservative states. They are not all blue or red. They include California, Colorado, Illinois, Nevada, New Jersey, as well as Arkansas. Nope, Alaska, AK is Alaska, Florida, Minnesota, Mississippi, Nebraska, South Dakota, Utah, West Virginia, Wyoming. So there are a lot of states that have already taken action on this. And to close, Madam Chair and colleagues, I will read you just an excerpt in case you missed it. In the Baltimore Sun, they did a wonderful editorial that talked about this bill. And they said, quote, Maryland taxpayers already pay for public education for such individuals. And they were talking about immigrants or foreign-born folks. And now, just at the moment when they can contribute to society in such positions as home health care aide or nurse, we would deny them that opportunity. At least 14 other states have chosen to toss citizenship as a requirement for occupational licensure. Maryland should join the club. And with that, Madam Chair, I will defer, happy to take any questions or defer to my fellow panelists. Thank you for your attention and interest. Hope we can move this bill.
Good afternoon, Robin Elliott. I'm here today on behalf of Don Graham, who I think you will hear testify virtually. Mr. Graham is involved in this issue. He works very closely with the foundation that funds scholarships for youth who are immigrants, many of them who are interested in nursing and other healthcare professions. So that's wonderful news.
Who is Don Graham? Who is Don Graham? Okay.
So, I wanted to just give some technical background information and then let you know I'd be happy to answer any detailed questions that you would have. Looking at this is a problem for all health occupational boards. They are trying to follow the law, which is very confusing, and essentially says that a social security number is required. So it doesn't say immigration status, social security number, but that's a de facto limitation on people who are not here as citizens. So what the bill does, and I think you'll see some technical amendments, we've been working very collaboratively with the boards to make sure we get them what they need, is looking at how do we alter the law in a way that would allow the boards to process applications. And we're going to hear some examples for people who are foreign born, who meet Maryland requirements, and who could very well be working here in Maryland right now, helping to alleviate our healthcare workforce shortages, but cannot because of the way our system works. And then finally, I'll just note that the National Council of State Boards of Nursing have identified that at least 19 states do not require a social security number for licensure. That number is probably actually higher because they might allow a workaround. And we're going to hear some about that from our next witness, I believe. Thank you.
Thank you. Madam Chair and Vice, my name is Opa Chiweshe, and I am the program manager for our International Nurses Program at Adventist Healthcare. We have 3 hospitals in Rockville, White Oak, and Fort Washington. We are currently sitting at a shortage of more than 400 nurses for our system, and we are unable, this is after all the efforts locally to find nurses. We are now have a pipeline of finding international nurses, and this gives us a fighting chance to close out that vacancy rate. When we sponsor international nurses, the nurses that are eligible for sponsorship have to have a USARN license. Now, they can only do that by actually applying to one of the state boards and getting an authorization to test. Because Maryland requires them to have a social security number, they are not able to get that initial licensure through our state. So when we go out scouting for nurses, it is a weird situation where we tell them that, oh yeah, we're really looking for nurses. We are hiring, we have a robust program for your training, but you have to go and get your license in Florida, Texas, Illinois, or any of the other states that allows them this opportunity. They do that. They pay all the fees, which are exactly the same, the process exactly the same as for Maryland. And then they arrive here, they have to come here a month in advance and wait for us to endorse their licenses in Maryland, costing us exactly the same amount of money and having non-productive nurses, experienced nurses sitting in a hotel waiting for this process and not serving our communities. This bill will allow us a fighting chance, will attract nurses to our state, and hopefully we can begin to serve our communities a little bit better. I thank you for this opportunity.
All right, good afternoon, Madam Chair, and to each and every one of you. So my name is Danilo C. Pamonag Jr., and I am an international nurse from the Philippines, and I work in the emergency department at Shady Grove Medical Center in Rockville, Maryland. And I started working since October 24th, 2022. So my journey to become a US registered nurse was really tough, considering the amount of money I earned in the Philippines, which is roughly around $300 biweekly. So I submitted my application form at Florida Board of Nursing, did my CGFNS and CES report, background check, and processed my school and PRC validation with a total cost of $880. After I got my authority to test, I applied at Pearson VUE for my NCLEX exam and enrolled at Review Center and UWorld just to pass the NCLEX exam, which cost me like $1,250. Luckily, I passed at first take and received a numerous offer from different hospital in different states. And based on my research, the hospital that I'm working with is one of the best hospital that I got an offer. I accepted the offer and they sponsored my visa immigrant process. I started to take IELTS and process my visa screen, which cost me a total of $1,025. I never thought that it would be inconvenient to process my license endorsement for Maryland because I have to move in USA 4 weeks before my start date at my hospital. Reason being is I have to process first my social security number, and it took me 9 days to get my social security. And after I processed my social security, I endorsed my license to Florida. Then it took me 2 to 3 days. Then after that, that is the time that I processed to Maryland. But I have to go through the process again and apply again for CES report and background check, license endorsement, other stuff, which cost me around $579. Coming from a third world country, this amount I spent was a huge money, especially I didn't earn a lot in Philippines. And there are a lot of nurses who are waiting, who wanted to work in Maryland, but they don't have a choice but they wanted to enroll to other, they wanted to like go to the other states because for the conveniency, they don't want to deal with the whole process. Thank you.
So good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I am Jane Kirschling, and I serve as the Dean of the University of Maryland School of Nursing. I am pleased to provide support for Senate Bill 187, including provisions requiring health occupation boards to allow the use of either a Social Security number or an individual taxpayer identification number for the health occupation's license, certification, or registration. Maryland is a party to the Multi-State Nurse Licensure Compact, which provides licensed nurses the ability to practice in other states within the compact. However, the compact requires provision of a Social Security number for licensure. Through a Maryland-only license, which allows applicants to use either a Social Security number or a federal ITIN, individuals without a Social Security number would have a pathway for practice in Maryland. The Migration Policy Institute indicates that in 2021, there were 17,000 DACA eligible individuals in Maryland, and 13,000 were youth and adults who were immediately eligible due to meeting age and education criteria. Maryland's healthcare system also benefits from graduates of foreign nursing schools. Allowing use of the ITIN would create another pathway for licensure and employment for those who meet the educational and language proficiency requirements of Maryland. In November of 2022, CogFins International released its inaugural report on nurse and healthcare migration to the United States. They reported that the top United States where nurse migrants sought licensure were Texas, Illinois, Florida, Montana, and Maryland. The majority of their applicants in 2022 were registered nurses, 81%, and many were migrating on permanent employment-based green cards, 70%. The majority of nurses applying in 2022 possessed a baccalaureate degree, and 60% of them were from the Philippines. Creating multiple pathways to licensure for nursing professionals will greatly benefit Maryland's healthcare system. Thank you.
Thank you very much. Senator Hershey.
Thank you, Madam Chair. Robin, if I could go back to something you had mentioned. First, is it anywhere in the code where health occupation boards are required to check for citizenship?
It's not in the health occupation codes where the confusion comes in, and understandably under family law, all occupational boards, so that would include plumbers and nursing, have to check for a social security number to see if somebody owes child support. This was a law that all states passed in about 1997. The actual federal guidance on how that law is interpreted says that what it really means is that a social security number is required if the applicant has one. The applicant could also have an ITIN. And then if the applicant doesn't have either, perhaps because they are just starting their process, as we've heard about some of people's journeys, they can sign a sworn affidavit that they don't have one. So that is the primary barrier to the health boards being more flexible in terms of how they process licenses.
Okay, so if I put this bill into two different parts, the beginning part of the bill just says that they must disclose the social security number or the ITIN, right? And you have that in two different places, right? So if an applicant has a social security number or an ITIN, could they be rejected for not being a citizen?
So not under family law. We do think that under health occupations, there may be a federal law that requires us to specifically acknowledge that people who are not citizens should be licensed. That's not a condition of licensure. We do know, as I think Senator Kagan may have mentioned, we think we need some tinkering with the language of the bill to get to exactly that concept. So, and we are working very collaboratively with the boards to find out what it is that they need to process these licenses.
Okay, I'd appreciate that because I'm wondering why the bottom part of the bill is necessary. If you've just said that if the de facto of determining whether somebody was not a citizen was asking for the social security number, now you've said we'll take the ITIN instead. Doesn't that make the bottom part of defining an immigrant unnecessary?
We had the exact same question, Senator Hershey, and we talked extensively with the boards about that, looked at all of their requirements. We do think that a version of the bottom of the bill is necessary. We may need some tweaking of the language to clarify that a social security number, an ITIN number, or citizenship status is not a condition of licensure. And then a second part is, of course, somebody comes over, they start working, they're gonna have to get that ITIN, that social security number, then they owe that information to the boards as soon as possible.
Okay.
So we think there needs to be a couple of revisions. And so the bottom of the bill may end up looking a little bit different than what you have before you.
I think that'd be appreciated by many. So thank you very much.
Thank you, Senator. So colleagues, we're going to go to Senator Bidle, then Reedy, then Ellis, then Lamb, then Guile. Senator Bidle. And by the way, we do have a total of 17 witnesses on this bill. So
Thank you, Madam Chair. I did want, thank you, Senator Kagan, for the bill, and Dean Kirschling, it's nice to see you in person. We've been on a few Zoom calls working on this workforce crisis. You threw out a lot of numbers and I maybe lost a little bit of track. So how many of, I guess, the immigrants do we think are RNs and LPNs? How much would this help our population of nurses in our hospitals? And
So of the immigrants that go through COGFINS, they are 81% of them are registered nurses. So it's a good number. And of the ones that come through, they're migrating on a permanent card, or 70% of them are. And then we know that we import the most number of nurses from the Philippines, with 60% of the immigrant nurses coming from the Philippines.
so we're in the thousands, are we talking about thousands of people that could now come to work if we
I
pass
think
this
you,
bill?
I think you could open the door to a number of people if we could deal with the Social Security issue,
Thank you.
particularly for registered nurses.
Thank you for your work.
Thank you.
thank you, Senator. Senator Reedy.
Thank you, Madam Chair. Yeah, maybe this question may be for Robin, but maybe anyone on the panel could certainly answer it. I'm having I'm trying to understand the connection between, like, I know we're importing nurses, as you just mentioned, from the Philippines and other places. I've had discussions with my hospital about the very issue of nursing. But is this bill partly because that's been a difficulty?
Yes.
I feel like we've spent a lot of time talking about one aspect of this bill, but I think the main point is, if we could do the I-10 for them, whether somebody lives if we just said if we just made it, you need a social security card or an I-10, does that take care of the issues that we have across the board?
Not across the board. Thank you for that question. For our nurses who are in the Philippines, most of them, they have no access to even getting the I-10.
So how are we, I'm sorry to interrupt you, but how are we importing them now then? They're doing this thing where they go to New Jersey?
Exactly. They go to another state. There are states that will allow them to sit for the licensing exam without a social security number or an I-10. And then they come here, then they endorse their license to Maryland.
Well, wait, though, we're not saying I thought the bill was saying now you can just use an I-10, but the bill is saying you won't need either one.
The bill would say that neither one is a condition of licensure. What I've learned, Senator Reedy, in my research on this bill, because I was not an expert on I-10s, nor am I a complete expert, but I know a lot more,
You could play one on TV anyway. Right?
right, is that you can't get an I-10 number until you've worked enough to owe taxes, because that's the way that the federal government collects from you. And so if you are still physically not in this country, it's very unlikely you're going to be able to get that I-10 number.
But several states are letting you take the test before you have either. Well, obviously you wouldn't have social security card, but before you could get the I-10, correct?
Correct.
So, but you would not be able right now to be hired in the state of Maryland, even if you had a hypothetical nursing license, unless you were here legally, correct?
So this does not change employers when they employ people. And I've done this, my employers, it's that I-9 form.
Mm-hmm.
You have to get 2 forms of documentation and write down someone's passport number. That doesn't change it at all.
So this is not about, and I think I knew this already, but this is not about whether someone can literally get a job here. If someone's not here legally now, no matter whether they grew up here or whether they came a year ago, if they're not here legally now, if we passed a bill like this, they could take the test, but they'd still have to be legally present in order to get a job in all likelihood in a hospital or correct?
Yeah, yes. In order to be an actual employee, they'd have to have some kind of legal status, because I think any hospital is going to fill out that I-9 form. And so that is really the in the primary pathway that people can work in this country who have clinical educations.
Thank you. Thank you, Madam
So
Chair.
just, if I can just add one sentence, it's not about whether you can get a job. It's about whether you can start a job. So you can get a job offer. You just can't start working there.
Thank you. Senator Ellis.
Yeah, thank you, Madam Chair, and thank you, Senator Kagan, for this bill. Let me get to one thing first. And describing, say, nurses coming in from Philippines or wherever, the word is used, my colleagues I'm sure know harm intent, imported nurses. When I look up the word import, it says bring goods or services into a country from abroad for sale. So I don't think we are talking about individuals when we say import. It seems like that's an odd word to say we're importing people. That takes me back to a previous time where Africans were brought in here for sale. And that term was used for that despicable practice. And so I think we should look at that word and not kind of use that word import in people anymore. So I just want to mention that. So being an immigrant, and my late mom was a nurse, and she came to this country and she functioned as a nurse before to this country. Employer has a need and they get a different visa for that skilled worker. And a typical
Hey, good afternoon and welcome back. We are still hearing Senate Bill 187. We have several witnesses signed up to testify virtually. We will begin with Nora Miller Smith. I think. Good afternoon.
Hello. Thank you, Madam Chair and members of the committee. My name is Nora Miller Smith, and I'm speaking in support of SB 187. I'm an RN and a member of the League of Women Voters Maryland. The League supports a system for unauthorized immigrants already in the country to earn citizenship and believes that immigration policy should also meet the economic and employment needs of the U.S. There is a healthcare workforce crisis in Maryland with 1 in 4 hospital nursing positions vacant. Inadequate staffing can lead to compromised care, clogged emergency rooms, closed units, and failed discharge plans. And Maryland's healthcare needs are growing. It's estimated that by 2040, 1.79 million Marylanders will be over the age of 60. Along with more nurses, Maryland will need additional licensed healthcare workers, such as certified med techs, certified nursing assistants to staff assisted living and long-term care centers, skilled nursing facilities, adult daycare centers, schools, group homes for individuals with developmental disabilities, behavioral health centers, and hospices. So one way to relieve the critical staffing shortage is by reducing existing barriers to obtaining licensure. With this bill, qualified individuals who have met all educational requirements would be able to use an ITIN on their application. Of note, ITINs are given to non-citizens so they can pay taxes, including. Good afternoon. Oh, I'm sorry. I'm sorry.
Oops. I see.
Including, so of note, ITNs are given to non-citizens so they can pay taxes, including even those who are lawfully present in the US, but who still don't qualify for a Social Security number. And undocumented immigrants do pay taxes. In 2019 in Maryland, they paid $375 million in federal, $260 million in state and local taxes, thus helping fund So we urge a favorable report and thank you very much.
Thank you very much. I don't see any questions, so we'll move on to our next witness. Thank you for your testimony. We'll turn to David Rodwin. No?
Good afternoon. Looks like the host has disabled my video, so I'm unable to come on video. There we are.
There
Okay.
you are.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is David Rodwin. I'm an attorney in the Workplace Justice Project of the Public Justice Center. Our Workplace Justice Project seeks to ensure that workers receive an honest day's pay for an honest day's work. I'll be brief. We support SB 187 for all the reasons others have already given. I'll just add that when immigrant workers are denied access to certain jobs, it makes them more vulnerable to workplace exploitation. When we allow qualified immigrants to receive health licenses, it brings them into the professional economy and reduces the likelihood of exploitation. And at the same time, of course, it helps our state address our increasingly serious healthcare worker shortage. So for these reasons and others, the Public Justice Center asks for a favorable report. Thank you.
Thank you. I don't see any questions from the committee, so thank you very much for your testimony. We're going to move to Mayor Selena Benitez. Good afternoon.
Good afternoon, and thank you for having me and for all the great work that you guys are doing. I'm sorry I couldn't join you guys. Busy in Mount Rainier, so I'm doing a testimony in favor of SB 187, Health Occupation License Certificates and Registration for Immigrants. As the city of Mount Rainier has led the efforts in the city of welcoming environment for all residents, including a vibrant immigration community, to make sure through actions and legislation that they know that they belong in their value. And as first-generation migrant whose family instilled the importance of giving back, I've always been an advocate for civil rights and the empowerment of minorities. And that's the reason why I'm in favor of Senate Bill 187. And I strongly urge you to support this bill as means of expanding employment opportunities to American community and equitable servicing of increasingly diverse population, and doing so benefiting all of Maryland. Mount Rainier is thriving in diversity with over 8,000 residents, the highest dense populated city in the whole entire state. So for us, it's important that if we have a lot more people working in the state. If anything, COVID has demonstrated to us the need in the health fields, as well as many years of knowledge that also shows that we need to have more people that represent various communities. The level of people of color that are not taken care of in the health department are very high. This bill will allow for people that are highly qualified to still work. At the end of the day, the TIN number as well as the Social Security number are doing the same thing, which is allowing people to report taxes. So to us, we see this as an expansion, but something that we need to be able to do. So I urge you guys to please vote in favor. And I do thank the sponsors and everybody that's supporting. Thank you so much.
Thank you very much for your testimony. There are no questions, so have a great afternoon. We will now turn to Don Graham. Good afternoon. Good to see you again.
Good afternoon, Madam Chair, members of the committee. I'm Don Graham, chairman of a company called Graham Holdings, co-founder of a scholarship fund called The Dream.us. I live in Washington, D.C. Our company owns businesses in Maryland, including 2 auto dealerships and the Clyde's Restaurant Group. I was publisher of the Washington Post for 21 years, and that gave me a deep admiration for this state and for everyone who serves in this body. 9 years ago, I co-founded a scholarship fund for students who are immigrants without documentation, some of whom have qualified for DACA and others who have not. We've partnered with over 70 colleges, including St. Mary's College of Maryland. Morgan State University will become a partner this fall. We've enrolled over 7,000 students nationally. They have a 76% graduation rate. They came to the United States at an average age of 4. We've graduated more than 50 Maryland Dreamers. This state has been generous to Dreamer students. It was among the first to give them in-state tuition and to give them the state financial aid their classmates get. Every legislator should be thanked for that. Today's immigrant high school students have different status. Many who graduated 10 years ago had DACA, including a federal work permit. This year, across the state, almost no undocumented immigrant high school graduates will be granted DACA. They will not have work permits or any way to get them, but they can work as independent contractors or entrepreneurs. There's a critical shortage of nurses and other healthcare workers in your state. More than 20% of our students major in nursing and other health careers. We'd ask you to open Maryland's healthcare licensure examinations to qualified applicants regardless of immigration status. This act will not disadvantage American citizens. It cannot be the case with this legislation because these students can work as contractors for a hospital, but they can become employees as citizens can. Thank you, Madam Chair.
Thank you for your testimony. There are no questions, so thank you very much for being here. Colleagues, we're going to now hear from the last witness on this bill, Lynn Nash. Good afternoon.
Good afternoon, Madam Chair and members of the Finance Committee. For the record, my name is Captain Lynn Nash. I'm the Communications Director for the Maryland Military Coalition. I'm also a retired nurse who completed over 30 years of service, and as a result, I understand the issue. I'm well acquainted with it. No one wants to have a healthcare provider take care of them or their loved ones who isn't competent and cannot read and write in English. This bill fixes that, actually allows for it. The process right now for a nurse to get a license, a foreign trained nurse to get a license, is really all encompassing, and it makes sure that the applicant is completely competent and able to work. That process is huge. They have to take a language test. They have to go through credentialing of their program. They have to take the NCLEX, a lot of things. So We're very comfortable with this legislation. We support this legislation, and especially we see it not only as a source of providers here in the state, but also as a source of providers for the uniformed services who aren't missing their goals of recruitment. So the coalition is a voluntary, nonpartisan organization representing 19 service organizations. We in turn represent 150,000 veterans in the state. We strongly support this legislation and ask for a favorable report. And as always, Senator Kagan, you're doing good work. Keep it up. Thanks.
Thank you. There are no questions from the committee, so thank you very much for your testimony. Colleagues, that concludes the hearing on Senate Bill 187. We're now going to go to Senate Bill 145, State Board of Social Work Examiners Temporary License to Practice Social Work. Good afternoon, Senator West. You can bring a panel up if you like.
Thank you, Madam Chair and members of the Finance Committee. It's great to be here and a pleasure to present Senate Bill 145. This bill is a reintroduction of Senate Bill 167, which passed both chambers during the 2021 session, but in slightly different form, and time ran out before the differences between the bills could be worked out. This updated version reflects the House amendments of Senate 167 as it was passed. There's a massive shortage of social workers in the United States, amounting to more than 10,000 social workers trained in mental health issues and substance use disorders. This shortage is projected to persist for some years, and the shortage exists right here in Maryland. This problem is being exacerbated in Maryland by long delays in administering the social worker exam. Right now, our schools are graduating many social workers, but they then have to wait for weeks or months to take the social worker exam. So over the weekend, all the advocates for various sides in this bill worked together, and we've produced an amendment which I believe greatly narrows the gaps between the proponents and the opponents of the bill. I'm hoping that the committee has a copy of the amendment. It's on a single page. And it's number 753129/1. So as amended, Senate Bill 145 would authorize, not require, the State Board of Social Work Examiners to issue temporary licenses to practice for applicants who, due to an administrative delay in the processing of an application by the board, have not been able to take their examination for at least 7 days, but have met all the other education and experience requirements to be licensed as social workers. The bill then would require the board to issue a temporary license if the examination is unavailable to an applicant for at least 7 days due to an unforeseen circumstance, act, or occurrence. Further, the license would be valid until 180 days after the examination becomes readily available. Under Senate Bill 145, the board would maintain the authority to restrict or regulate the temporarily licensed social workers, however it sees fit. And the bill explicitly provides that a social worker holding a temporary license is only authorized to practice social work under the supervision of a board-approved supervisor. So that's what the bill as amended would say. I appreciate the committee's consideration of Senate Bill 145 and would hope for a favorable recommendation and would be happy to answer any questions the committee might have.
Good afternoon, Madam Chair and members of the committee. My name is Teresa Hessler, and I'm here today representing the Maryland Association of Resources for Families and Youth, also known as MARFI. The members of MARFI represent providers who serve Maryland's most vulnerable children who are in and out of home placements due to abuse, neglect, or severe mental health and medical needs. Our members are social workers, operate group homes, treatment foster care programs, and independent living programs, primarily serving the foster care population, as well as the juvenile services program. We are here today asking for your support on Senate Bill 145. If passed, this legislation would authorize the State Board of Social Work Examiners to issue a temporary license to practice for a period of 180 days. At this point, an individual has already completed their schooling, their training requirements, and their background check. They would still have to practice under a board-approved and licensed social worker while under the temporary license. As you will hear from many others here today in support, this is just one practical tool in the toolkit for the Board of Social Work Examiners to use if the exam was unavailable due to unforeseen circumstances, such as another public health crisis or malware attack. It is for these reasons that we politely ask for a favorable report. Thank you.
Good afternoon, Madam Chair and committee members. My name is Steve Acerno. I am the Director of Treatment Foster Care at the ARC Northern Chesapeake region, and we serve kids in foster care from all across the state. I just want to make one point today, but I think it's a really important point that this is already happening here in Maryland, that there are people who are finished with their graduate program, ready to enter the workforce, and can get hired in the public sector without a license. My program, as well as some of my colleagues' programs, we cannot do that because we're private providers. And so we want this bill to pass so that everyone who's coming out of graduate school has that opportunity, whether they want to work in the public sector or the private sector, to get started, as long as they're under the proper supervision.
Good afternoon. Thank you, Madam Chair, Vice Chair, and Senate members. My name is Chloe Bernardi. I am the CEO of Hearts and Homes for Youth and a licensed clinical social worker in the state of Maryland. I think it's important to note that we're not proposing this bill as a solution to the workforce crisis. We're just offering this bill as a tool in our toolbox, should we need it, to overcome barriers that may present themselves. As we've spoken about a little bit, the impact of the staffing shortage for programs such as the ones that my colleagues and I run means that we cannot fill our programs to full capacities, and we're frequently having to deny placement for kids in child welfare. As a result of that, they're living in motels or sleeping in DSS offices and contributing to the overstay at the hospitals, which is also a significant issue in Maryland. We see that as a public safety issue. It's impacting the kids, the families that we work with, and ultimately the community. If this bill were to pass, these folks would be licensed and then under the supervision of a clinical supervisor. They'd be covered by the agency's insurance, and they would not be allowed to exceed the 180 days. And as an LCSWC supervisor, I would ensure that we were adhering to those guidelines, because I'm not going to compromise my license, my agency's license, or the integrity of social work. It would be very similar to using an intern, which we do, and they're significantly helpful to our programs. And again, this is just there should we need it, not as standard practice. So we ask for your favorable vote. Thank you.
Good afternoon, Madam Chair and Madam Vice Chair and members of the committee. My name is Simone Bramble. I'm the Executive Director of Presty Ridge. We are a nonprofit organization here in the state of Maryland providing foster care services, independent living, as well as workforce development services across the state. What we're asking for with this bill is, again, for us to support the state in placing kids in homes where they belong, not in a hotel room, not in an office anywhere. And part of the work that we do is to provide, along with our partnerships with foster parents, safe environments for kids. When we're not able to hire social workers, it means that we have to limit the capacity of who we serve, meaning that the kids who get referred to us by Department of Social Services can't come to us because we're bound by caseload sizes. So the less social workers we have on our workforce, the less kids that we can serve. And our goal is to serve as many kids as possible, getting them in safe environments. There's been some talk around the test that is connected with becoming a social worker and getting your license. What we know is that there's some disparities around that exam. We're not asking that the test be forgotten at all, but that we are asking that the temporary license be issued so that, again, we can really ease that burden that the state has right now. So we can get folks into a job. Doesn't mean that they don't do a background check. We still want all of those things. As someone who hires social workers all the time, we want to know that kids are safe. So that is part of what we're asking for. And we hope that you will definitely give us a favorable report. Thank you.
Thank you. Senator Guile.
Thank you, Madam Chair. I think this is a question for the bill sponsor, but just so I understand, and perhaps you already said this earlier, but what's the cause for the long delays in the state administering the social work exam?
Actually, I can't answer that. I'm told that
Okay.
they exist, but I don't know why they exist. Perhaps somebody else on the panel knows why they exist.
What this bill specifically speaks to is should there be a circumstance that delays, so like COVID, the malware attack, everything was
Okay.
significantly delayed. So I don't have the specific data in regards to the delay, but there's typically a backup, whether
Okay.
it's processing. There's a lot of paperwork that has to be processed before you're approved to sit for the test, and then the test, you have to find a date for the test. So that process can sometimes be significant, but with COVID, with the malware attack. So this is really in place should something like that, an administrative delay or unforeseen circumstance like pandemic happen.
Senator, I had the bill the last 2 years, and when I first introduced the bill, COVID was the problem. There was a desperate need, and the need wasn't being filled. And so this was a way to add more social workers to the system because the exams couldn't be given in a timely fashion because of COVID. Now, the COVID problem seems to have receded, but this is now an arrow in the quiver of the Board of Social Workers that they can pull out as needed in the future.
Okay, thank you. Yeah, my question was more, so is this some special circumstances, which it sounds as it is, not so much there existing some sort of administrative or labor shortage type issues and that's administering the exam such that this is a problem that we need to maybe address separately. So thank you for that.
Thank you, Senator. Senator Ellis.
Thank you, Madam Chair, and thank you, Senator West, for this bill. I have a question for, I think, Mr. Serno. I think, did you mention that certain categories of social workers can function now without a full license?
So someone coming out of graduate school who's ready to enter the workforce but doesn't have their license yet can right now be hired in the public sector without a license, and they have that 180 days to sit for the exam and pass the exam. Folks in the private sector don't have that option because of regulation.
Okay, so this bill would extend that to the private sector.
Yes, if the test was unavailable for those reasons. Yeah.
Great. Thank you. Yeah. Thank you, Madam Chair.
Thank you. Any further questions for the sponsor or the panel? Senator Mounts.
Thank you, Chair. Just one quick question. I was reading the opposition testimony and it was focusing on competency. And while the proponents are at the microphone, how would you respond to criticisms of this would create a problem with competency?
Well, there's a lot that's been said about the exam being one of the strongest components of being a competent social worker. For us and for me as a practicing social worker myself, I've gone through 4 years, 2 years of graduate school. I've had a field education, actually 2 field placements, as well as I've sat for the exam. We know a lot of folks who are social workers who are practicing right now, and particularly if they are moving toward advanced licensure, they might not pass the test. And they might not pass the test because what we know now is that there's a lot of disparity around test takers. And this is a national problem. The ASWB, which is the Association for Social Work Boards, released some analysis this past August around the exam. There's a lot of issues. Hopefully those can be addressed in short order. But right now, what we know is that to be a competent social worker, it's not just about the test. It's about your training. It's about your education. It's about field placements. All of those things matter, not just an exam.
And if I could add to that, the bill specifically provides that if somebody practicing under a temporary license, which is no more than 180 days, can only practice under the supervision of a board-approved supervisor. So it's not like these people are going to be just sent out into the world with no supervision. They're going to be practicing directly under the auspices of a board-approved supervisor.
Thank you.
Sure.
Thank you, Senator. The Vice Chair has a question.
Yes, for Ms. Ramble, how many hours in the course of being in school do you have to work as an intern, or you have to get those hours in different placements? Is that correct?
Yes, so your first year, you have a field placement. There's also a second year field placement as well. So, you know, you work,
It's
16, yes, 16, the first year, 16 hours, and then the second year, 24 hours.
a week.
Yes.
For the
So
entire-
you do get and different kind of opportunities to work with different people. So you do have
Absolutely.
that. And I think that's very important to
Mhm.
note that you do have that. And a test sometimes is not quite the best way to say your expertise, in my opinion. And if you have a chance maybe to follow up with me, I'd love to talk to you about the social
Sure, we would
worker
love to.
test. So
Thank
if you can get my information, I would love that. So,
Thanks, Madam Vice
Thank
Chair.
you.
Thank you. Senator Lamb has a question.
Sure. Thank you, Madam Chair. And this question's to follow up on what Ms. Bramble just said. The board will contend that there's a public safety issue here. But you had also cited, and I think it's interesting to note, because I heard a statistic, somewhere along the lines of this fact, and maybe you can verify this for me, that there's a huge disparity between first-time board takers, between white individuals that take the board exam and Black individuals that take the board exam. Something to the effect of like 90% of white individuals that pass the exam on the first pass, and only like 50 or 55% of Black test takers pass through the exam on the first pass.
And I don't have the exact numbers in front of me, Senator Lamb, but what we do know, and again, this is not just a Maryland issue, this is a national, issue. And the analysis that the ASWB provided is also broken down by schools across the country. So in the state of Maryland, you can see where different schools of social work, how they're performing around the exam. And again, those numbers are also very revealing as it relates to, the demographic of test takers by school and their access to exams and how they pass. This is also an economic issue. And Vice Chairwoman, I would love to talk to you about this because it goes beyond, again, what we're talking about as it relates to, just one exam, but it's access. If I am, a student about to graduate and I need support taking the exam, then I have to pay for that. Not everybody can do that. So those are also issues that we need to talk about. Lived experience as an issue as well, as we as the board is looking at, how they develop questions, for the exam that really would support eliminating some of those disparities that we see.
So the point being, there's tremendous disparities in folks who end up taking-
Absolutely. And to use the exam as a barometer right now, as the one thing that makes me a competent social worker, is a mistake, given what we see around those disparities.
There's some implicit bias, I guess.
Absolutely.
Okay. Thank you, Madam Chair.
Thank you. I see no additional questions for the sponsor of this panel. Thank you very much for your testimony.
Thank you.
Thank you.
We'll now call forward Frank Boston, Ari Plout, Kyle Tilden, and Nicole Smith, who've signed up in support of the bill. Good afternoon.
Good afternoon, Madam Chair and members of the committee. I'm Frank Boston III, and I'm here on behalf of Presley Ridge. And we appreciate your support for this bill. Thank you, Senator West, for introducing the bill. The history of the bill is that back in 2021, it passed the Senate 47 zip. It ran into trouble in the House. We're back again, albeit in a different committee. You've heard the testimony. This is just a tool in the tool chest, something that they can use in case there is an administrative delay. So I'm here to try to answer some of the questions. Senator Guile, I think the board will testify that if there's any delay, it's because of the shortage of staff right now. Otherwise, we're not in the middle of a ransomware or malware attack. Senator Mouts, to your questions, the bill speaks directly to it. You can only sit for this temporary license after you've completed the appropriate educational, after you completed the appropriate education and experience requirements. Further, it goes on to say that a temporary licensee can only work under the supervision of a board-approved supervisor. And so, you know, that answers that question. Senator Lamb, to the point of being a public safety issue that they'll testify, we agree it is a public safety issue. Having children sleep in hotels in the offices of DSS is a public safety issue. Having temporary licensed social workers can help address that issue, because we can, you know, you have to have a certain number of kids per worker. So if you have more workers, you can address more kids, we can get them out of those offices. Regarding the amendment, oh wow, it's 15 seconds. We did work with the other side, and we attempted to reach out to them, and we've had conversations. We are changing the shall to an may. This gives them the flexibility and discretion to use a temporary license as they see fit. I'll stop right there.
Madam Chair, Madam Vice Chair, esteemed members of the Senate Finance Committee, my name is Ari Plout, and I'm here on behalf of Presley Ridge, also in support of this bill. I just wanted to focus on other states that have enacted the similar legislation that allows temporary licenses. There are about 24 or so states that have similar legislation where there's a temporary, when you can issue a temporary license. For example, Wisconsin allows, and I submitted this as written testimony as well, but basically those who meet qualifications for the social worker certificate, except for passing a required examination, would be entitled to a temporary license. And in addition, Connecticut, the department may issue a temporary permit to an applicant for a licensure as a master's level social worker who holds a master's degree from an accredited social work educational program, but has not yet taken the licensure examination. So this is basically what we're asking for. And in addition, the state, there are similar boards that also have temporary licenses in Maryland. For example, the Board of Occupational Therapy issues temporary licenses to some of their people that are in the field of occupational therapy. And with that, I would ask for a favorable report. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Nicole Smith. I am a licensed social worker, and I'm here on behalf of the Board of Child Care. We are a nonprofit organization that delivers critical human services to Maryland's most vulnerable families, but we also have a Mid-Atlantic footprint as well. Last year, we served 1,300 families. One of the unique aspects of operating both here in Maryland, where we're headquartered, but also in other states, is we've been able to experience what Mr. Blount had explained as far as temporary licensure. In West Virginia, a state that we operate, there is a temporary license that aligns with the Senate Bill 145, and basically verbatim allowing social workers to be able to practice on a temporary basis after graduation. This has really helped keep services flowing throughout different areas in the last 3 years, whether it be the pandemic or other issues that have impacted the workforce. I also wanted just to call attention, as my colleagues did, to the impact and how much we value and need social workers to deliver our services. Over the past 3 years, Board of Child Care has been challenged to employ licensed master's level social workers as well as the advanced licensure. And because of that, we've had to reduce our residential treatment programs capacity by 50%. Because of that, our kids are Maryland's children are being served in out-of-state programs, as well as languishing in hospitals and other environments that are not meeting their medical conditions. And because of that, we want to be able to have more flexibility, so there are no barriers to our workforce that are needed so that we can serve the families of Maryland. And because of this, we respectfully ask for a favorable report.
Hello, Madam Chair, esteemed committee. I just wanted to make touch on a few points very briefly, if I may. Oh, my name is Kyle Tilden. I'm here on behalf of Presley Ridge and the Social Workers Coalition. I did want to note that the Board of Nursing also allows for temporary licensure. And I wanted to touch very briefly on the point of racial disparities and how this bill may solve that, in that in the case of another, God forbid, another COVID or any other major delays, we see that communities of color and marginalized communities are most directly affected by these things, by these unforeseen circumstances. We want to make sure that there are people there and available to treat these communities, and especially people who look like them. And given the way that the test has panned out, in that Black individuals are not passing the test at a higher rate, this actually provides an opportunity for even more Black social workers to be available to those affected communities in the event of another COVID, Black or other marginalized communities. I yield my time. Thank you.
Thank you. Senator Hayes, then Senator Guile.
Thank you, Madam Chair. I've heard this narrative a couple of times this afternoon, and I'm not a social worker, nor do I pretend to play one on television, but I know a lot of social workers and I honor the profession. And I think there's some validity and some merit to this piece of legislation because there is a shortage and that very needed profession. But the fact that young people in the state of Maryland are staying in places instead of homes is not strictly attributed to the lack of social workers. I believe some of the contributing factors are due to Maryland's policy on placements and not having some of the more intensive care that our young people seek and need. And so I just want to be careful and that we don't misrepresent the validity and the merit of this very important piece of legislation that's before us. Isn't that so?
Thank you, Senator.
Thank you,
Senator
Hayes.
Guile.
Yep.
Thank you, Madam Chair. So when you keep saying this is just a tool and tool chest, I guess, for the board. So this just gives them the authority, doesn't require them to issue the temporary license, correct?
Initially, the bill did require.
Okay.
That's the way we put it in as a shall. But we took it back to the way because we took it back to the way that the body had passed it in before with the word may.
Okay.
That's the I have a copy of the amendment, but
That's what had passed previously.
Yeah.
What passed.
yeah,
Okay.
with the word may.
And then, so I assume, I mean, we use this phrase unforeseen circumstances. So the board is the one that makes the decision if there's some unforeseen circumstances. There's no obviously definition to it, but they get to make the decision. We're unable to, get to providing this examination to these potential social workers. And so we get to issue them this temporary license, correct?
Right. So if it's unforeseen circumstance, act, or occurrence that prevents the examination from being offered, I guess the situation dictates that, if there's another, pandemic or something. But if does the board get to make that decision? I guess the answer is yes.
Okay.
We gave a lot of flexibility. After much consideration, we gave a lot of flexibility on the administrative delay because they needed to have some discretion. And in speaking with them, there's other delays going on that have nothing to do with the test. We also put language in the state if the test is unavailable to be offered. So we really wanted to narrow the scope of what we were talking about. And they have the discretion. We tried the word shall because we didn't want the board not to do it. We wanted the board, if someone's ready to take the exam, after 7 days, give them an exam. But after speaking with the board many times, the Board of Social Work Examiners and other opposition, we understand that they need to have that discretion. And we realize it's consistent with the other temporary licenses that are offered by other occupation, nursing and health occupations. So it's being consistent.
Okay.
Yeah.
Thank you. So it just gives them a great deal of flexibility if they decide. So.
Yeah,
Right.
and
Yeah.
hopefully the board sees it as a tool. That's been our thing, that we decided that was our thing. It's here in case you need to use it. Because I think what happened during the pandemic, during the I think the following year was the ransomware attack in the Department of Health. The board said, we wish we could, but we can't because the law doesn't provide, nor do the regs provide for us to issue a temporary license. So, no one's in the office, things are closed, no one's offering the test. We need people if there's a backlog, but there's nothing we can do. So being proactive, we weren't around, but being proactive at that time, that's how the legislation, that was the impetus for the legislation, I should say.
Okay, thank you.
Thank you, Senator. Senator Ellis.
Yeah, thank you, Madam Chair, and thank you for your testimony. So I'm following this bill because I guess what I got is from all the testimony and understood previously is a shortage of social workers, correct? In the system that can't help all these needs that are out there. So get more social workers in the system under supervision. That's the bill.
Yeah.
And you had me. And then when you come and you said you'll insert the word may, the board may do this. That remind me of a example, driving on 95 or 97 and you see a speed limit, you may drive 55. I mean, it has no teeth. So why all this fight and then say you may do this? I mean,
yeah.
Could you satisfy my curiosity with that, please?
So you raise a good question. I guess the best way to answer that is we are hopeful, as all professionals are, that if there is a situation where they can see it as a tool, that they will do it. In our conversations, and again, I don't want to speak for the Board of Social Work Examiners. One of the things they brought up that did resonate with us is there's a shortage of staffing. And, that they don't have enough staff to do the other administrative duties, much less issue a temporary license. So when they get staffed up and hopefully the allocation is there for that, they hopefully will see it as a tool. If there is another pandemic, if there is, God knows what else comes up, a flu in the office that everyone's out for a little while. This is something that they can use in their discretion as it may. If it never gets used, to your point, when it should be used, to your point, then we'll be back next year or the year after to seek the word shall. That's the answer. So you should know we just found out today in this very space on temporary licensing for social workers. There's two other bills introduced today by Senator Washington. One does away with the test completely. So that's coming to you for another day in front of this committee.
Thank you, Madam Chair.
Hey, thank you very much. I see no additional questions for this panel. Thank you very much. We'll bring forward Ann Seacott, who is signed up favorable with amendments. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Ann Seacott. I'm testifying today on behalf of the Maryland chapter of the National Association of Social Workers. And we do support temporary licensure, which is why we were involved in bringing the bill forth beginning a couple of years ago. The sponsor is correct. This was in direct response to COVID, because what the shutdown did was it shut down the access to the test. And while we aren't in that current situation, we still feel like this would be a great thing, like other boards have and have used to be able to sort of turn that on when there are, as people have mentioned, either another pandemic or some kind of technology problem like you all maybe experienced today. So I also want to acknowledge there is absolutely a workforce shortage problem. It is not exclusive to social workers. Your colleague, Senator Beidel, heads up an entire commission on workforce shortage issues in the healthcare field. And we absolutely have some bills this session that may try to address some of that. There's more to come for sure. It's not going to be fixed overnight. This bill is not going to fix the workforce shortage. This bill, at least in terms of its original intent, was really about trying to make sure that employers are not at a disadvantage when they're planning on hiring the folks that they just had as interns, who, they figure, all right, hopefully they're going to pass that test and I'll be able to hire them, and they can't. That's the kind of thing that this kind of bill can prevent. I also want to acknowledge that people have mentioned other problems, and those problems exist. There's a delay in getting licenses through the application process, and we do believe that the board is working on that. There's absolutely a very evident bias in the national test that exists, and you are going to see bills on that. And NASW is absolutely committed to trying to figure out both a short-term fix to that issue as well as a long-term fix to that issue. But in the meantime, yes, let's add this tool.
Thank you. Questions for this witness? Senator Lamb.
Thank you, Madam Chair. And Ms. Seacott, I think you probably have a perspective of how some of these other boards have addressed this challenge during COVID as well. It seems like this has been particularly exacerbated with the Board of Social Work, and that's why this led to the impetus of this bill by the sponsor a couple of years ago. Can you speak to why the Board of Social Work seems to believe that they can't issue these temporary licenses without this legislation?
So I believe it's simply because it does, they have to have the authority to do it, is my understanding, that they do have to have the statutory authority, and then they would promulgate the regs to be able to implement that. Because right now it's, you have to, in statute, it is, you have to take a test. You have to pass this test in order to get the license. So I think that absent something giving them permission to create this temporary license, they don't have that authority.
Okay, and so the other boards seem to have had some other flexibility to be able to provide these licenses or overcome this challenge or not have this obstacle during COVID because of how their statutes were written.
Yes, they already had that authority.
Okay. But this would grant the social work board similar authority to what the other boards already have.
Correct.
Got it.
Thank you, Senator. I see no further questions for this witness. Thank you for your testimony. We'll call for Daphne McClellan and Sandra Petty. Signed up unfavorable. Good afternoon.
Is this on? Okay. Good afternoon, Madam Chair and members of the committee. I'm Daphne McClellan. I'm the Executive Director of the Board of Social Work Examiners. I would like to address some of the inaccuracies that were said earlier, but I'll wait until those come up in questions. I wanted to particularly address two concerns that I have about this bill. One is that the bill is predicated on the idea that people have experience and education when they are granted this license. These two licenses addressed in this bill, the LBSW and the LMSW, are for people who just graduated. They have no experience. They do have education. Most concerning, though, is the language about unforeseen circumstances, acts, or occurrences, which is addressed as shall. That is not part of the may. That was the amendment. We don't understand exactly what that would mean. The language seems quite vague and permissive. There's a 7 business day period. We don't understand when that would start, what would be considered an unforeseen circumstance. Does that mean the exam is not available to any applicant, or is it only not available to this particular applicant? Is it because they tried to register for the exam and the next time an exam is available, because all the testing center spots are occupied, is 8 days down the road or 15 days down the road, and so it's not within that 7-day business period? The other thing that is equally confusing is then when it is available to everyone. So it also talks about there's 180 days, a period after the examination is readily available. So what's the definition of readily available? Does that mean that now there's 2 slots available for the person to register, or does there have to be 20 slots? So we just feel that the language about the unforeseen circumstances is very vague. As the administrator, I can tell you that we do not have the ability to determine every single person who might come to us and say, I tried to register for the exam and it's not available for 7 days. We can't handle that. So I appreciate the time, and I hope that you vote unfavorably for the bill. And if you have any questions, I'm happy to answer them.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Sandra Petty, and I am the current chair of the Maryland Board of Social Work Examiners. I'd like to clarify a few things that have been also said earlier. And one of them is that Maryland does grant students within 6 months of graduation the ability to take the licensure exam. They got a waiver from ASWB, and that is something that they are allowed to do. So if they graduate in May, they can take the test in January. So let me just, kind of clarify that for folks who were not aware of that. The other thing is that Maryland actually does have a temporary license for other social workers who are licensed in other states in good standing. They're allowed to practice for at least 6 months while they're waiting for their license to get endorsed by us. So I just wanted to put those things out there. A lot of discussion today has been about in the child welfare system, that children are sleeping in hospitals and everywhere else. This bill is not about that. This bill is about temporary licensure. For 45 years, Maryland has had licensed social workers, and we have not had a need for temporary license. And the exams have been taken within a reasonable amount of time. So I just wanted to also say those things. The unforeseen event was COVID. And hopefully we will not have another event like that takes place. So quickly, as I see my time is moving, the test centers were only closed for 2 weeks. When they did open back up, they had to practice social distancing. Time was a major problem. There was a lot of test anxiety. And by year 2, the testing was back on track. There are 4 testing sites in Maryland, Baltimore, Columbia, Salisbury, and Bethesda. And because it is a national exam, folks can take the test in the District of Columbia, Delaware, and Virginia. I'd like to just also make sure that I point out, if you just give me an extra second of time, is that Marylanders actually passed the test on a 78.5% first time for just the LMSW. And then for the clinical exam at a 78.7%. And that's what Maryland's, we do better than the national average as far as test taking is concerned. Anyone practicing after the 180 days would be subject to fines. So there's a lot more I could say, but also consider who's presenting, the child welfare folks, about employment issues and what have you. So that's all I have.
Thank you very much. Senator Ellis.
Thank you, Madam Chair, and thank you, ladies, for your testimony. Ms. McClellan, you brought up several unclear items in the bill. So I was on the impression that with legislation, we give the board generally broad direction, and then you would write the regulations to define those ambiguities. It's just, we don't want to really prescribe to exactly how to do that. So what would be different with this legislation with the general practice of we provide the broad guidance and the department or board will basically work with our intent to do regulations to make it clearer and more defined?
My concern is that the way the bill is written where, and we did ask when we've had we've had a couple of meetings prior to coming here today, we did ask, what do you mean by unforeseen circumstances, acts or occurrence? And the answer was, well, they're unforeseen, so we can't say. It sounds to me like this is it sounds very individualized. So if we are talking about an individual applicant, and I think that's how our applicants will read this, they'll say, oh, for me, the test isn't available in 7 days. And that's what I'm concerned about. We license about 900 LBSWs and LMSWs a year. And so if we have to consider every person who might call us and say the test isn't available for me in 9 days, we will never get any other permanent licenses handled. So yes, we could write regulations, but it's hard to write a regulation around something where the statute itself is not clear to begin with.
Okay, thank you.
Thank you, Madam Vice Chair.
Thank you. Would either of you be able to get a copy of the test that you have to take?
No, that's a closely guarded test. I mean, they have a couple of versions of it that the test is only administered in these Pearson View centers. And even during COVID, it was not available online. So it's, for people like to take from home or something like that. So no one has a
Yeah,
copy of the test that I
Because
know of.
I have heard complaints from some folks and says it is very disparity. And I can't tell because I don't know what it says and how the versions go. So
I think that, the bills that Senator Washington has written are, that's her effort to address those issues. And we will be back, I'm sure, to talk about those in a week or two, but that's not what this bill.
no,
is
I
really
know,
about.
but I'm
Yeah.
just trying to get ahead of myself. So
Thank you.
thank you.
Thank you. I don't see any additional questions from the committee, so thank you very much for your testimony. Feel free to communicate. Oh, Senator Lamb.
Thank you, Madam Chair. Ms. Petty, you had cited the fact that currently, I guess under COMAR, there's the ability for the board to grant folks that may have been licensed in other states to be able to practice social work here for up to like 6 months?
6 months, yes. If you're in another state and you meet the same requirements as Maryland, you can work in our state for 6 months while you're waiting for your license to be processed. And those things are done fairly quickly.
So how does that jive with the public safety argument that the board keeps making about the fact that these temporary licenses to these other individuals would present a public safety concern?
Because they're already licensed in good standing in another state.
Okay. And then I think you had also brought up the fact that, the pass rate of this exam, the national exam is like 70%.
That's Maryland's rate, and we're above the national rate. I was trying to find my statistics. I think it might be 70 something, but ours is better.
Okay. Is it also accurate, because I'm looking at data, which I think is from Maryland, that there are significant disparities between Black candidates who take the exam and white candidates who take that exam?
There's disparities between all of the ethnic groups. Yes, that is correct.
Okay. All right. Thank you, Madam Chair.
Thank you, senators. Now I'm looking around to make sure I've missed. Okay.
Senator Griffith, could I answer?
I'm gonna have to we do have a number of bills left and a number of folks that have been waiting quite a while to testify. Feel free to communicate with the committee members offline. Thank you so much for your testimony.
Thank you
Colleagues,
all.
that'll conclude the hearing on that bill. We're now going to move to Senate Bill 201. Senator Hester is presenting the Maryland Medical Assistance and Children's Health Insurance Programs, School-Based Behavioral Health Services Reimbursement. And so we'll invite those that are leaving to leave quietly. Thank you. And Senator Hester, if you want to bring your panel up, you're welcome to do that.
Thank you, Madam Chair. I actually don't have a panel. There is somebody here from the consortium staff who is available to answer questions. Would you like them to come up? Okay. Senator Katie Fry Hester for the record. Chair Griffith, members of the Finance Committee, thank you for your consideration of Senate Bill 201. The COVID-19 pandemic had huge impacts on the mental and behavioral well-being of our students. Everyone knows someone who suffered, friends, family, neighbors, with anxiety, depression, or substance abuse. However, this trend was not new. Even prior to the pandemic, suicide had already surpassed homicide as the leading cause of death for teenagers. Let me say that again. Suicide is the leading cause of death for teenagers, and this bill is part of the solution. In 2020, the General Assembly included in the blueprint for Maryland's future the establishment of a state consortium on coordinated community supports partnerships. These are partnerships between the school system and the community to support student behavioral health needs by maximizing public funding through Medicaid and other sources. Now, the success of this consortium model will rise and fall based on the cooperation and support we have with our community-based providers. In the blueprint for Maryland's future, the General Assembly also included resources for these partnerships. So in fiscal year 2022, there's $25 million in the budget for mental and behavioral health services. This grew at $25 million a year to $125 million in coming forth in the year 2026, and it holds at that level going forward. So this bill is not an ask for money. The resources are already there. Over the past year, this consortium has been busily working to build out the Medicaid reimbursement framework alongside a hub and spoke model, which is still being developed. The consortium is chaired by Delegate David Rudolph and staff from the consortium from the Maryland Community Health Resource Commission, and I have Mark Luckner with me today, and they're ready to answer any questions you may have. As I mentioned, this consortium was legislatively creative, and we have on the group also MSDE, MDH, cabinet secretaries, members of multiple professions. It's been a really fabulous experience for me to be on it myself. So Senate Bill 201 is the next logical step in the implementation of the consortium's work. It requires the Department of Health to apply to the Centers for Medicare and Medicaid Services for a state plan amendment in order to do two things. First of all, to reimburse all medically necessary behavioral health services to all students, not those students who have an IEP. That we're currently doing. Secondly, it requires reimbursement for administrative claiming, basically the cost of administering the program. The bill also expands the type of providers that can be reimbursed. The consortium has done a quick review of 5 of the different types of providers, and 3 of the 5 have credentials which are very similar. To be clear, in this model that we're suggesting is not untested. Similar changes to state plans have already been adopted in Michigan, Florida, California, and 13 other states. This means that millions of children in other states are currently receiving these critical services through their schools, but in Maryland, they are not. Specifically, when Michigan moved to expand their services, their schools went from providing services to about 100,000 students to almost 900,000 students, from 100,000 students to 900,000 students. Colleagues, there is a lot of interest in the bill, as you will see from folks behind me and the bill folder that you're looking at. Today, you'll hear from many different stakeholders. I want you to know that the consortium is still working on clarifying 2 operational issues, but neither of these should prevent or slow us down. The first issue is this difference in licensing requirements between MSDE and board certified staff. In other words, the requirements for certain MSDE staff are slightly different than the board licensure at the state level. So we're working on that, and 3 of the 5 different categories are fairly similar. The second issue is who and how the administrative claiming will be handled. This is an issue of ongoing discussion, an operational issue, and once again, should not prevent the Department of Health from taking the first step to apply for the state plan amendment. There are many other amendments you'll hear today, and I'm open to working with the committee and with the advocates to get a bill that works for everyone. Colleagues, we have to remember why we're doing this. Suicide is the leading cause of death among teenagers. How many of you remember going to a graduation where somebody wasn't there? I went to several this past year. This bill will help to ensure that those children who need help the most can access it. Their lives may literally depend on it. For these reasons, I respectfully request a favorable report on Senate Bill 201.
Okay. Questions for the sponsor? Senator Reedy.
Thank you. I didn't know if we were going to hear from the whole panel. Senator, I was looking at the bill here and I've been getting more and more familiar with these. I know we've done some work on this already. What is the when it says medically necessary, who determines something is medically necessary when they go to one of these centers?
That is a good question. I would defer to the staff of the consortium.
Okay. Yeah. And when we talk about the expand, there is certainly incredible need. So definitely want to work on it. I was just curious about that. So thank you very much.
Thank you. Were you here for questions or you have testimony?
So this is Justin. He's with the State Department of Education. He's got testimony.
Okay.
Mark Luckner is here for questions from
Okay.
the staff of the consortium.
Okay. Do you want to hold on that or do you want to address that now? Okay, you can proceed with your testimony.
Okay.
Thank you. My name is Justin Dayhoff, Assistant State Superintendent at the Maryland State Department of Education. I'm here today on behalf of State Superintendent Chaudhary and the department to request a favorable report from the committee on Senate Bill 201. This bill gives Maryland the opportunity to expand the number of students eligible for services that qualify for Medicaid reimbursement and expand the types of services eligible for Medicaid reimbursement. In 2014, the Centers for Medicare and Medicaid Services reversed its free care policy. That policy limited Medicaid billing to students with IEPs or IFSPs. These are also students who generate Blueprint special education funding in the Blueprint formula. Students who otherwise require mental or behavioral health support, who did not have an IEP or an IFSP, and whose family could not afford care, had few options. Under the new CMS policy, state plans could allow any student qualifying for Medicaid to be eligible for Medicaid reimbursement for school-based services, even if they didn't have an IEP. This opened an important policy window, and as Senator Hester noted, since then, 17 states have expanded services. Maryland has not. It's time for Maryland to catch up. Senate Bill 201 requires the Maryland Department of Health to amend the state's plan to leverage the new CMS policy as updated in 2014 and, with that amendment, allow for Medicaid participating students to receive school-based services eligible for Medicaid reimbursement. Senate Bill 201 also expands the types of positions that can provide covered services that students can receive, for which LEAs with local education agencies would then be eligible for Medicaid reimbursement, including school-based social workers, nurses, counselors, and psychologists. This expansion also allows local education agencies to bill for school-based administration costs, which include marketing to expand participating students, direct costs for billing and administration for the program, including the staff necessary to administer and submit billing forms. To illustrate the potential of this, Massachusetts has a comparable number of public school enrolled students. In 2016, CMS noted that Massachusetts sought reimbursement for $188 million in school-based services and administration, compared to Maryland's $78 million that same year. Difference is substantial. The bill has an opportunity to expand services to many of Maryland's highest need children at no cost to the state. It is a win-win for Maryland's children. We respectfully request a favorable report.
Thank you very much. Questions for this witness? Okay, thank you for your testimony. We're going to call forward Labrina Hopkins, Nathan Farrell, Rob Garagiola, and Lauren Lamb. Good afternoon, and you can proceed with your testimony.
Good afternoon, Madam Chair, Madam Co-Chair, and the members of the Senate Finance Committee. My name is Labrina Hopkins, and I'm a certified special educator. I have served as a self-contained special education teacher, resource teacher, and IEP chair during my 22 years in Baltimore City Public Schools. I am also the Secretary Treasurer of AFT Maryland and a member of Baltimore Teachers Union, AFT Local 340. As an educator, I asked this committee for a favorable report for SB 201. You have my written testimony, so let me just highlight a few points. In Baltimore City, we have a very diverse population of students with diverse array of needs. Our schools have a large number of students that have required mental health services through an IEP, which was mentioned in earlier testimony. Districts are able to bill medical assistance for these students. Much of these funds go to staffing for those related service providers. However, we in city schools have a large number, and I'm certain there are numerous students in similar situations throughout the state that need special education services, that need special services, but do not have an IEP. Under current state law, districts are not permitted to bill for services for students that do not have an IEP, even though the federal government does say these students are eligible. If we change this law, districts will be able to bill for students without IEPs, and they would have access to federal revenue streams that would allow them to be able to hire additional mental health providers to render those services. Members of the committee, every student in the state has a constitutional right to a high-quality educational program. And as it stands right now, Maryland is leaving money on the table in the form of federal dollars that are meant for students with special needs. Again, I call for a favorable report for SB 201. Thank you.
Madam Chair, Madam Vice Chair, and members of the committee, I'm Lauren Lamb. I'm here on behalf of the Maryland State Education Association, and I urge the committee to support Senate Bill 201. MSEA represents 75,000 educators and public school employees across the state with 39 local affiliates. As others have noted, it is no secret that students have been struggling in the wake of the pandemic and amidst a school personnel shortage, and that includes behavioral health providers. MSEA has participated on the Maryland Consortium on Coordinated Community Supports, along with Senator Hester, and we agree with the assessment that this is a needed next step in providing additional behavioral health support to students. Maryland school Medicaid coverage currently extends to services provided as part of a special education service plan. But with a state plan amendment to expand school Medicaid, Maryland has an opportunity to maximize federal funding and expand eligible behavioral health services to students without an IEP or IFSP. While we urge mindfulness in the implementation of Medicaid services as not to further strain our behavioral health providers' workloads, we believe that there are models from many other states that show that this step can provide benefits for staff and students alike. 21 states have either already expanded school Medicaid or are in the process of doing so. It's time for Maryland to join them and take advantage of the full federal funding available for school health. We urge the committee to issue a favorable report on Senate Bill 201. Thank you.
Madam Chair, members of the committee, Rob Gergel with Compass Advocacy here on behalf of NAMI Maryland. We are enthusiastically supportive of SB 200 and thank Senator Hester and Senator Augustine for leading this effort. It's a very important bill. NAMI Maryland has submitted written testimony, and I'll just highlight a few things. Obviously, the need is great. I mean, the need is great. And COVID, frankly, exacerbated that need over the last several years. And we also know that early intervention is critically important. And schools are our front lines when it comes to young people. And so we can leverage federal dollars that were basically, as was said earlier, leaving on the table, one for one, that many other states since 2014 have taken advantage of. I don't know if the number is 17, I thought it was 1721, but regardless, a range of states since 2014 have embarked on this. And you heard the numbers with respect to Michigan, 9-1. So 100,000 young people were getting mental health services in schools in Michigan. And when they did this, 900,000 children were getting those services. You heard the resources with respect to Massachusetts that was provided earlier by MSDE. We can be doing this. We should be doing this. Would urge a favorable committee report for SB 201.
Good afternoon, Chair Griffith and members of the committee. My name is Nathan Farrell, and I'm a Spanish teacher with Baltimore City Public Schools, and I'm asking for a favorable report on Senate Bill 201. I've submitted my full testimony to the committee, but I'm going to deviate just for some personal remarks here. It's about a decade ago that the Obama administration created this important opportunity for school districts to be able to receive the reimbursement for student health services through the Medicaid program. And this is a game changer for Baltimore City Public School students. I really need to emphasize that my students are entitled to these funds and they deserve them. Maryland can bring in federal dollars to cover the cost of health services that are already being provided in schools, and that revenue can also be used to hire the additional staff that we are desperate for to expand services to provide care to significantly more children, improving healthcare access, not only for my students in Baltimore City Public Schools, but for the 721,604 students in the state of Maryland that are eligible for Medicaid and CHIP funding. That's according to CMS as of October of this past year. I don't know how to emphasize how desperate we are in Baltimore City Public Schools to expand this and draw down on these funds so that my students can receive the services they are entitled to. I am imploring that this committee please review the fiscal note. How often do we get to look at fiscal notes where we get money? Review the fiscal note, please, and please pass a favorable report on Senate Bill 201. Thank you.
Thank you. I don't see any questions for these witnesses, so thank you very much for your testimony. All right, colleagues, we'll turn to John Woolhams, Lauren Grimes, Ann Geddes, and Reagan Vaughn. Good afternoon, and I have one signed up favorable and 3 favorable with amendments from this group. All right, good afternoon.
Good afternoon, Madam Chair. John Woolhams, representing the Maryland Association. Good afternoon, Madam Chair, members of the committee. John Woolhams, representing the Maryland Association of Boards of Education. Delighted to be here today in support, strong support of Senate Bill 201 for all of the fact-based and logic-based and reason-based reasons that you've heard, and the passion that you just heard related to the need for these services. I will share, and I spent a lot more time in a committee down the hall and down the stairs than in this committee over the years, the Senate Education Committee, but I am the son of a long career school psychologist. And so the issues of student mental health and school-based mental health services are very near and dear to me. And this bill really strikes that chord to hold down available funding. As was said, leaving money on the table really makes no sense, and money that translates into direct services to benefit students and their families and our communities is what this bill is all about. Yes, there are some issues raised in the fiscal note related to the local share provision that is apparently currently paid by MSDE. We would certainly rather the state pick up a tab than shift it to the locals. That's pretty par for the course in our advocacy. So we hope that that can be looked at. But all in all, it's a very, very good bill, and we strongly urge a favorable report. Thank you.
Good afternoon, Madam Chair and committee members. My name is Lauren Grimes, here on behalf of the Community Behavioral Health Association of Maryland in support of SB 201 with amendments. CBH represents 108 community-based mental health and substance use providers who serve the majority of adults and children accessing care through the public behavioral health system. CBH members provide an array of outpatient and residential treatment, and they also have clinicians on the ground in 63% of Maryland's public schools and delivered school-based mental health services to over 20,000 children last year. Our members weave together funding from insurance payers, Medicaid, and county contracts to support the delivery of school-based services. This work is underfunded and is not reaching all of the children who need mental health supports in schools. For this reason, we strongly support efforts to expand the services already delivered. However, we want to ensure that efforts to do so will not unintentionally reduce access to care in the community. Therefore, there are 3 things we want to offer for consideration as Maryland plans for a successful expansion of school-based mental health services. Firstly, we want to expand services, not replace them. School partnerships with community clinics not only connect students with licensed therapists, but also a broad array of other services, including medication management and care coordination. We want to ensure that the access to these services is preserved. Secondly, as you have heard all day today, the nation is in the midst of a workforce crisis and behavioral health has been hit, Medicaid providers specifically. We are also facing down a youth mental health crisis, both of these things simultaneously. As schools seek to hire more mental health professionals, they do risk competing for limited qualified staff with Medicaid providers. Partnerships with community clinics ensure that we don't reduce access to behavioral health services in any setting. And thirdly, complex Medicaid billing rules do pose potentially serious coordination challenges that could cause a reduction of service access for children and unbillable services for community providers. These challenges must be addressed to ensure children can access behavioral health care in the school and in the community. To reduce these unintended risks, we've offered 2 amendments to the legislation as proposed. You have those in our written testimony. Thank you for your time, and I am happy to take any questions.
Good afternoon, Madam Chair and members of the committee. My name is Reagan Vaughn. I'm the Director of Advocacy for Catholic Charities of Baltimore. For 100 years, Catholic Charities has been providing care and services to Marylanders in need. And that includes through our behavioral health clinics, where we are in 100 Maryland public schools offering the school-based behavioral health services that have been described today and billing Medicaid for those services. We
support this bill because we want to see the expansion of those services. We can't meet the complete need there. But we have offered the same amendments as CBH to make sure that the expansion of Medicaid in the schools for school employed clinicians complements the community work that's already going on, complements the funding that has been budgeted for the consortium, and doesn't end up reducing community supports in the community. There can be an argument and a policy decision on who should be in the schools, whether it should just be school provided or just be community provided. But what I can tell you is when we're in a school, we bring the full resources of the local clinic with us. So we have a clinician in the school, either part-time or full-time, meeting with students physically in the building, but we can offer family therapy. From the clinic, we can offer 12 months a year and see students during the summer. We have our psychiatry team who can do medication management, and then we can also refer to PRP services. So there is a value to having the community-based supports in the school. And we want to make sure as we expand school employed services in the billing of Medicaid, that again, it's a parallel track and a complementary track to the community providers who are already in the schools. I believe Lauren mentioned it's about 1,400 of our public schools already have partnerships with community providers. So with that, we would ask for a favorable with amendment. Thank you.
Thank you very much. Vice Chair, then Senator Reedy, then Senator Ellis.
Just a quick question. We just had a bill that took a long time about social workers and not having enough of social workers. Do you see it? Do you think that there's going to be a problem even getting people to fulfill this mission? I mean, I'm for it all the way, but that's what everybody keeps saying to me when I bring that up. They said, we don't have enough.
If I might, I think the struggle is what we don't have enough of is clinicians to stand up a Medicaid workforce within schools and maintain the community capacity that we currently have. CBH members are seeing significant turnover of staff, and there are open slots that we are not able to treat the children that come to us because we don't have enough staff currently. So Medicaid providers have been in the community have been hit very hard by this. And if there is competition for those clinicians, that limited workforce created by school employed staff, it will strain both the community and the schools.
So we'll see how it works. Let's just get more mental health workers.
Madam Vice Chair, if I may, MABE is very much interested in growing the pipeline of not only teachers and paraprofessionals and school bus drivers and cafeteria workers, but also related health professionals and the folks eligible to bill Medicaid under this legislation. And pulling down that federal money that's currently left on the shelf will help us boost our ability to hire professionals, boost our ability to build partnerships with community-based providers, and let students know that there's a job out there with a minimum starting salary of $60,000, good benefits, and it's something that you as a junior or senior in high school should think about going to community college and then to a four-year institution and continue to work and serve your community. And so this bill, to my view, is part of a much broader effort to really bolster the promotion of the value of working for public school systems in the state, including in these vital health fields.
Senator Reedy.
Thank you, Madam Chair. And I think for Ms. Grimes and Ms. Vaughn, either or both of you, a couple questions. I'm trying to be sure I understand how this works at the school level now. So right now, how does a child interface with your services? How do they get to you?
It depends on the school and the county. We're in
Understood.
5 different counties and they all work very differently, or 5 different jurisdictions, Baltimore City and 4 counties. Normally it's a referral through the school. The principal knows we have the partnership, and a student can be referred by a teacher, a guidance counselor to our clinician for services.
Okay, I'll just stop you right there for a second. So that's because of a behavior issue or because of an observable issue of some kind?
It could be a range of issues. They've gone to the guidance counselor and it's beyond what the guidance counselor can offer. It could be a parent has asked for support. It is any behavioral health need. And we serve students without IEPs. So it's not something identified through the IEP. It's this population we're looking at in this bill.
Okay, but this bill is about getting Medicaid funding for a student who doesn't have an IEP or one of these issues, but they already come to you. It's just not funded by Medicaid dollars.
No, we are billing Medicaid through the clinic. It is that the money is not running through the school. This would have the Medicaid dollars run through the school. Our model is the Medicaid dollars run through our clinic.
Why is it an issue that it doesn't run through the school? I know it's not your bill, so maybe that's a question for somebody for.
In theory, the school could probably contract and bring a provider in, but we already have the surrounding services. The school would not be able to bill for psychiatric services.
Okay.
That's not permissible, or the family therapy. And so if we have the child within our clinic, we can bill Medicaid for that full range of services.
So what this bill would do would be able to set up, and perhaps in a perfect world, the way you both are describing, your organization could be part of that, setting something up where it would be inside the school. Because right now it's not literally inside the school, correct?
It is literally inside the school.
Oh, you're set up inside the
Yes,
school.
we are in the schools.
Okay. I won't belabor this point. I'd like to understand this all better, like how it's working now. Number two, are parents aware and do they give authorization right now for their child to receive services from you? From either one, not from you two, but you know what I'm saying, from your two organizations. Do parents currently have to authorize their minor child receive?
I believe
services?
last year you changed the law on that. But yes, for the
For
most
counseling,
part,
yeah, I mean, for something more medical, you still got to get parental authorization, but for
yes,
counseling.
we
so-
are getting parental consent.
So it's fair to say that in this bill, which we all agree there's a huge need and we want to help children, but it is fair to say now that if we pass this bill as is, you're going to have children the idea is more of them will be accessing mental health care, but we don't have the same safeguards of parental notification that we did 12 to 18 months ago, correct? As it relates to counseling services.
The law itself changed.
I
correct,
understand.
And so it becomes a standard of care for the clinician to make that determination, I believe, whether it's school-based or not.
Oh, go ahead. Yeah, Ms. Vaughn. Yeah,
School
go ahead.
employed or not.
I just wanted to clarify it because it is quite confusing. When we talk about community clinics having contracts with schools already, they have clinicians who are employed by the community clinic on-site in schools,
They do.
delivering.
They are in the
services
school now.
The billing happens at the outpatient mental health clinic. So at the authorization level, that child can access a range of services because they are connected to the clinic. They're receiving the service in the school though.
Right. And so if we pass this bill and perhaps passed it with some kind of amendment like you both have suggested, you all would be able to, how would that change what you do? You would still be in the school, of course. How would it change what you all do besides that?
Oh, I think we're hoping it doesn't change too much, except that more children would have services. We just want to make sure we're expanding and not creating a competition between school employed clinicians and community employed based.
The last thing I'll say, and I won't miss, Madam Chair, I'll try to get more clarification offline. But I do think this is an important point because, so we're saying we want to go from, like in Michigan, they went from 100,000 to 900,000. Well, they went from 100,000 to 900,000, but people getting paid for through Medicaid, or they went to 800,000 more children receiving services. And I'm not asking you to answer that question because you're not here to talk about Michigan. I'm just trying to understand how this whole process works. And I do have a larger concern about, the issue of parental notification, but that's maybe a separate issue. And it's certainly not anything you guys are involved in. So thank you very much. And I appreciate your answers.
Thank you. Senator Ellis.
Thank you, Madam Chair. And as testimony went forward, there are some acronyms thrown out, and so IAP was used. What's that IAP?
An individualized education plan. So currently, if a student in a school has an IEP and it requires services
that can be billed for Medicaid,
You
the
said IEP,
IEP, Individualized Education Plan,
so the IAP.
IEP.
IEP, okay,
The school can bill Medicaid for those services if it's part of the IEP.
okay. And there's another acronym, someone used, is IASP, or was that IESP? Someone threw that out.
I think I used that one.
Senator, it's related to the IEP and it's the Individualized Family Service Plan, the IFSP.
IFSP. Okay, Individual Family Service Plan. Now, what's that in relation to the IEP, Individual Education Plan?
So, Senator, so the IEP is developed by school professionals and parents to meet the learning needs of a student with an identified learning disability that affects their ability to grasp and progress through the content. And so, as opposed to a 504 plan, which is a medical condition or disability that also impacts their learning. And so we have IEPs, we have 504 plans, and then you have these individualized family service plans, which are separate and can contain more information around services such as counseling and family services, not the services directly provided to the student in the school setting.
Right. And so I think someone alluded to there are a lot of students who maybe are eligible for the IEP, Individualized Education Plan, but they're not assessed. Is that true? Somehow they're out there, and because it's a complicated process, very expensive.
So I think the way I would, I think answer that question might be to look at something like ADHD or oppositional disorder and some of the conditions that students experience that don't typically rise to the level or meet the qualification standards for an IEP. They're not federally recognized disabilities that trigger that whole formal process. And yet the guidance counselor may recommend that this student with their family's consent seek counseling and behavioral therapy, psychiatric counseling, panoply of services. And this bill will certainly help school systems pull down the federal Medicaid funding to help support those services. I don't necessarily believe it's an immediate competitive threat that we're going to be able to go out and hire people at the volume at which we're going to be competing with the private providers who are here at the table with us, who we do definitely want to remain close partners with.
Okay, and one last clarification, Madam Chair. I think Ms. Vaughn, you said in your test something similar to a PRP service. Did you?
Sorry, the Psychiatric Rehabilitation Program. It's another service that can be offered in an outpatient clinic to youth who need extra support. It's normally delivered by a paraprofessional.
Okay, and that's for someone who has a IEP, Individualized Education Plan, or is just?
No, it could be something that is determined as part of their case management. That is an additional service that they need.
So what's a PRP again, please?
Psychiatric Rehabilitation Program.
Okay, great. Thank you. Thank you, Madam Chair.
Thank you. I don't see any additional questions for this panel, so thank you very much for your testimony. We'll call forward Deborah Brocato. Okay. Don't see her, so we'll move to our virtual witnesses. Brittany Johnstone. No.
Good afternoon.
Afternoon.
My name is Brittany Johnstone. I am a school psychologist for Baltimore City Public Schools, and I work at the Baltimore Teachers Union currently. I'm here today speaking on behalf of the Baltimore Teachers Union in support of Senate Bill 201. The Baltimore Teachers Union represents hundreds of clinical professionals working in city schools who provide a comprehensive continuum of services to support students with and without identified disabilities, IEPs, and IFSPs. When this guidance was issued a decade ago, which clarified which services.
Well, so when Senator Kagan got this language from the AAP, you know, as I understand, the AAP draft bill, which is being floated through all 50 states at the moment, doesn't include.
One moment, please. We're gonna try to get this technical difficulty corrected. Apologies to you.
Not a problem. I can
Yes.
start whenever it's
2023,
ready.
baby. All right. All right. You can proceed. Sorry about that.
Okay, not a problem. I certainly appreciate even the ability to testify virtually, so thank you. This guidance has been issued a long time ago. Since then, LEAs like city schools have been forced to leave money on the table. By removing this barrier to reimbursements and expanding the number of eligible services that are billed, we can bring in federal dollars to cover the cost of students that, to be clear, are already being provided to students without IEPs. Data from other states has shown that when programs are expanded, millions of dollars in additional funding becomes available. And this is a sustainable funding stream that can help districts more effectively plan and provide services. So we just ask provide a favorable report for Senate Bill 201.
Thank you very much. I don't see any questions from the committee, so thank you very much for your testimony and your patience. All right, colleagues, we'll hear from our last witness on this bill. Megan Montgomery signed up unfavorable in opposition to the bill. We're
Good afternoon. I'm so sorry. I've had a challenge getting off mute. My name is Megan Montgomery. I'm here representing the Love Maryland PAC, speaking unfavorably about Senate Bill 201. While a well-intentioned bill, I'm sure this bill is really a solution that, you know, doesn't have a problem. All of the services that are outlined to be covered by this bill are actually already able to be covered under an IEP, and an IEP ensures that parents and students and the school are working together in the student's best interest. As the mother of a minority male child in a Title I school district, I have seen IEPs do incredibly good things for students because there is a three-legged stool there to work toward protecting and providing the student with the best information and the best access to healthcare, and not having overlapping care that comes from parents struggling to try and provide care that with this bill, they may not know the student is already getting in school. So we really ask for the committee to issue an unfavorable report for this bill. Not only is it unnecessary, but it puts parents in a very disadvantaged position when they are trying to utilize their own scarce financial resources to try and provide, care that a student may, as it turns out, already be getting in school. I know that there are some concerns about where a line of, parents' involvement ends and a child's, autonomy begins, but we really can't have that line being at the disadvantage of the child itself.
Okay, are there any questions for this witness? Thank you very much for your testimony. I see no questions. So colleagues, that will conclude the hearing on Senate Bill 201. We're going to turn to Senate Bill 161, State Board of Physicians dispensing permits. Senator Lamb.
Thank you, Madam Chair. If I can ask Mr. Dudzik and Ms. Kaufman to come up as part of the sponsor panel. Madam Chair, Madam Vice Chair.
Beard.
Yes. I'll go ahead and begin. So good afternoon, Vice Chair Klausmeyer and other members of the committee. For the record, Clarence Lamb, Senator District 12. Here to introduce Senate Bill 161 on behalf of the State Board of Permits. This bill would increase protections for the public and also expedite discipline against physicians who improperly dispense drugs. Under current law, a physician cannot dispense a drug without meeting the requirements set by the Board of Physicians. Currently, physicians with a dispensing permit are inspected by the Office of Controlled Substances Administration, or OCSA, the Office of Controlled Substances Administration. And they do this within 6 months of receiving their permit, and then once every 5 years during the term that they have the permit. So OCSA goes in to inspect these physician offices during that frequency. OCSA then takes their investigation report and forwards it to the Board of Physicians. The board then has to review the report and decide if there are potential violations of the state's Medical Practice Act. If the board believes there is a violation, then the board has to do its own inspection in order to gather evidence that's necessary to file charges against the physician. The board then has to go through its own disciplinary process in order to take action against the provider. At this point, a significant amount of time has passed and the provider in question is still providing care. We believe that by consolidating the inspection process, it would be possible to speed up the discipline process and also ensure that unethical or questionable providers are prevented from practicing as quickly as possible. Additionally, this bill will result in increased inspection frequency because the board will be tying the inspections to a 2-year period instead of a 5-year period. There seems to have been a lot of confusion amongst the opponents of this bill, whom you may hear subsequently. For example, and you'll see this in the written testimony as well, Epic Pharmacy says in their letter that this bill is able to reduce burdens on physicians. However, this bill does not in any way reduce the burden on physicians. It just expedites the process of taking action against any questionable physicians who've been engaging in these practices. Although my office also spoke to the Maryland Pharmacists Association, there seems to be a gap in the understanding of this point as well. In their letter, in the Pharmacists Association letter, they state that they want swift action when it comes to revoking the permit from a questionable physician. But that's exactly what this bill does by seeking to consolidate the process and increasing the frequency of these investigations. The letter also incorrectly states that under this bill, physicians will only have to take 2 hours of dispensing continuing education in order to maintain their dispensing permit. However, current regs clearly states that all 10 hours are required for dispensing physicians. There is also a letter from the Attorney General in the written testimony, which is a little more complex to explain. The Office of the Attorney General appears to be concerned that by moving inspection authority to the board, this would impact criminal investigations, which we believe is inaccurate. First, as far as we can understand, there has never been a criminal referral to the Office of the Attorney General resulting from an OCSA investigation. This has not occurred. OCSA has given some referrals to the Office of the Attorney General, but these are not inspection related. So we do not see how changing the inspection body, who's actually conducting the inspections, could possibly impact the Attorney General's office criminal work. The Office of the Attorney General is also able to get access to records needed for their criminal work via subpoenas. And finally, OCSA will continue to maintain authority over all physicians through their controlled and dangerous substances registration, the CDS registration, which is separate from a physician's dispensing permit. It's also important to note that the Office of the Attorney General's criminal investigations can take a very long time, and there could be very good reasons for this, but it's important to note that these providers in question then should be prevented from practicing as soon as possible, and that's what this bill does. There was recently a high-profile pill mill case that took the Office of the Attorney General 6 years in order to charge. Meanwhile, the Board of Physicians had already taken action against the physician. Passing this bill will allow the board to further speed up their processes to ensure Marylanders are protected from questionable providers while the Office of the Attorney General develops their criminal case, which can take a while. The Attorney General's letter also includes several amendments that are, we believe, overly broad and address issues that are not directly relevant to this bill. Additionally, their amendments seem excessive. For example, one of their amendments calls for a special investigation process for the Board of Physician members who hold a dispensing permit as part of their clinical work. The members of the board are appointed by the governor. The members of the Board of Physician are appointed by the governor. They're vetted by the Executive Nominations Committee and also approved by the Senate. This additional layer seems unnecessary and offensive to those who are serving on the board to have to go through this additional level of investigation simply because of their service on the board. The board also has a robust conflict of interest policy to handle any situation where a potential conflict would arise. We've asked the Attorney General's office if they can point to any examples of the board being impacted by conflicts related to dispensing, and they were unable to provide any examples. Thus, without any clear example, we strongly believe that we should not be creating a special investigations layer on top of board members. That being said, we're certainly open to amendments to help make the Office of Attorney General more comfortable with the bill. The current bill requires the board to report any violations regarding controlled and dangerous substances to OCSA, the investigators that are currently involved. I'm happy to report that the Office of Attorney General to add the Office of the Attorney General to that section as well, so that they receive notifications, any violations. This would allow their office to immediately begin a criminal investigation of the board while they continue their work. Additionally, I'm also open to clarifying the uncodified section of the bill to ensure that OCSA continues to have access to their records. Overall, this bill will help, we believe, alleviate unnecessary delays in conducting inspections by transferring responsibility of the inspecting permit holders from OCSA to the board. It will also minimize delays in the investigative process and expedite the board's ability to conduct disciplinary action. This will increase patient protection and be a more cost-effective as well as quicker process for dispensing permit inspections. I'd like to thank the committee for their time and turn it over to the other members on the sponsor panel. Thank you.
Does any committee member have a question for the sponsor? Okay, Matthew.
Good afternoon, Madam Vice Chair, members of the committee, Matt Dudzik with the Maryland Board of Physicians. Thank you for having me and thank you to Senator Lamb for this bill. As the Senator outlined, this bill is specifically dealing with the inspection of physicians that hold dispensing permits. So these are specifically the permits that would allow a physician to dispense some medication directly from their offices rather than sending the patient to a pharmacy. Ultimately, the core of this bill is patient protection. Senator Lamb outlined a lot of the major issues that we encounter, so I won't reiterate them, but I do want to emphasize that the current system is failing to adequately protect the public. Under the current setup, there are significant delays and hurdles to enforcement that can jeopardize the health and welfare of patients in Maryland. So what the bill does is very simple. We are the agency that issues these dispensing permits. We are the agency that is charged with disciplining physicians when a violation occurs. We are the agency that would be responsible for revoking this permit if that issue comes up. This bill would allow us to take charge of the inspections as well. All of the standards and requirements for dispensing physicians are remaining the same. This bill also does not remove the authority of the Office of Controlled Substances, which still has authority over any physician that prescribes or dispenses controlled substances under the criminal law article through the CDS registration. Regardless of your stance on physician dispensing, it is happening. And right now, the primary safeguard that's in place, which is this requirement that they receive regular inspections, is both minimal and just very difficult to enforce. We believe that SB 161 would take significant steps to fix this, and I urge the committee to submit a favorable report.
Thank you, Madam Vice Chair, members of the committee. My name is Dana Kaufman. I'm here on behalf of MedChi, the state's medical society, and we do support this bill. We believe that the transfer is a much better use of state resources and will create a more cohesive system. I just wanted to also give you a little bit more detail about physician dispensing. So right now there is about 35,000 active licensed physicians in the state of Maryland. only about 650 of them hold a dispensing permit. So this is a very, very small percentage of the population. I would imagine everyone here in this room or somebody that you know has had their medication provided to them by a dispensing physician, because if you have gone to an urgent care center, that is how you get your medication. And if you're like me, when you walk out of that there, you are very happy to have your medication and you are taking the first dose before you hit your vehicle. So that is really the essence of the physician dispensers. With regards to the Office of Controlled Dangerous Substance, it's also important to know that 65% of dispensing physicians don't dispense controlled dangerous substances, only the remaining 35%. So again, when you consider the fact that there is only 650 dispensing physicians, that is a very small portion. They again still fall under the jurisdiction of the Office of Controlled Dangerous Substance through their CDS registration, which they have to have. We also think that transferring the inspection authority over to the Board of Physicians is a better use of the resources of the Office of Controlled Dangerous Substance, where they can focus their attention on that very serious task that they have and not on the overall inspections for the entire physician dispensing community. And with that, we ask for a favorable vote. Thank you.
Are there any questions from the committee? Seeing none, we'll go to Zach Shirley, who is when virtual and favorable with amendments.
Good afternoon, Madam Chair. Thank you for this opportunity. I just wanted to take a couple of minutes this afternoon to explain a bit of context around our concerns, because I don't know that, I mean, we've submitted our written testimony, but there needed to be a little more detail, I think, to really explain our concern. In-office dispensing is a bit of a blind spot for us in our opioid practice, because one of the easiest ways for us to find pill mills is to look at Medicaid data, farm the data, and see if we can line up and find pharmacy claims where someone gets their pills paid for by Medicaid, but we can't find where the doctor billed, because that's a pretty good sign that the doctor's charging cash, and that's a red flag for us. That's how we find pill mills, and that doesn't work when there's an in-office dispensing permit in place. So that makes us really dependent on this oversight. So any bill that's going to make oversight more robust, I'm in favor of. But there's another consideration when it goes under the Board of Physicians that we don't have to deal with right now with the Office of Controlled Substances. And that is Health Occupations 1410 and 411. That specifically, I mean, 14410 is called records not admissible or discoverable, and it specifically says that the records of the Board of Physicians are not discoverable or admissible in evidence, including in a criminal case. Now, I know we've had discussions and people have differing interpretations of the statute, but the truth is the statute's ambiguous. It's unclear, and I can't risk an investigation to go have the court tell me that I'm wrong or I'm right, because we spend too much time and the stakes are too high. I can't take that chance. So we've asked for amendments to 14410 and 411 that will make it clear that we, the Office of the Attorney General, can use the records of the Board of Physicians in our criminal trials. If we can get that amendment, I think this is great, because it removes that obstacle. And like I said, anything that makes the oversight more robust or more efficient, I'd be in favor of. But until we address the elephant in the room that I can't use what BOP produces, I don't know.
Zach, you're from the Office of the Attorney General, is that correct?
That's correct, yes. Specifically the Medicaid Fraud Control Unit.
Okay, does anyone have any questions? Oh, see, that's that seat there. It's a tough corner. It's a nice corner. So ask your question, please.
Thank you, Madam Chair. So
Kramer.
Is there an opportunity for you to engage in a conversation with the bill sponsor to see if this issue can be addressed so that it satisfies the goal of the bill sponsor, but addresses the concerns that you've expressed? Quite frankly, once again, this is not my wheelhouse, but I do sit up and take notice when the Office of the Attorney General comes to the table with significant concern. And I'm just hoping that maybe that is something that there's a resolution to that would ease my mind with regard to the goal of the legislation and the concerns you've raised. So perhaps
Yes.
there will be an opportunity for that to occur.
And I will say, we had a conversation with the Board of Physicians, and then we had a follow-up conversation with Senator Lamb's staff on, I guess it was a week ago Monday. We are addressing this. The truth is, we all have the same goal. I think we just have different priorities and how to get there. So I believe that I think we'll work it out.
Good. Okay. Thank you for that. Thank you, Madam Chair.
That's the
Push your
end.
button.
That's the end of this bill. And we'll go on to Senate Bill 188. Is that correct?
Senate Bill 188 is the Public Health Rare Disease Advisory Council, Senator Lamb. And if you have a panel, you're welcome to bring them up with you.
Thank you, Madam Chair. We do have a panel. If I can ask Ms. Morlino, as well as Ms. Brannon, Ms. Whedon, and Ms. Carr to come up to the sponsor panel. While they're on their way up here, I will go ahead and begin. So good afternoon. Thank you, Chair Griffith, as well as members of the committee. For the record, Clarence, I am Senator District 12 here to introduce Senate Bill 188. This bill's purpose is to establish a rare disease advisory council to study and make recommendations on matters relating to individuals with rare diseases in the state. Per the 1983 Federal Orphan Drug Act, a rare disease is defined as a disease that affects less than 200,000 Americans, which means a disease that affects about 9 out of 10,000 individuals here in the country. Although individual rare diseases are uncommon, about 1 in 10 people have a rare disease. So in aggregate, having a rare disease is about as common as having diabetes if you were to take that in total. It is essentially certain that each of us at least has several constituents who have a rare disease, just given the statistics of this. Some well-known rare diseases include sickle cell disease, cystic fibrosis, ALS or Lou Gehrig's disease, and hemophilia. However, there are thousands of other rare diseases that are not as well known to the general public. Because individual rare diseases are so uncommon, it is often very hard for impacted families to gain attention of researchers, the medical community, as well as policymakers. To help address this issue, members of the broader rare disease community have begun to work together to develop a rare disease advisory committee in several states. And currently there are 24 states that have rare disease advisory committees, and 7 states in addition to Maryland that are considering legislation to create similar equivalent committees. Although the specifics may vary, rare disease advisory committees generally follow a similar pattern based on input from local rare disease advocates in the community. They bring together individuals with a variety of different connections to the rare disease community and task them with developing recommendations on how a state can better support individuals with rare diseases. The work of a rare disease advisory committee can include recommendations on improving insurance coverage, supporting transition to adulthood for kids with rare diseases, or educating the public about resources for individuals with rare diseases. Some successes that other states have seen in their rare disease advisory committees include developing a registry for clinicians to provide care for transition-age children and young adults. Another example is creating a resource bank for individuals living with rare diseases. Third example is creating information guides to support self-advocacy in the rare disease community. And lastly, coordinating with health occupations programs to support patients and families, including providing rare disease information and curriculum for healthcare providers. I've recently received some questions about whether a rare disease advisory committee overlaps with some of the work of the state's existing state advisory council on hereditary and congenital disorders. Although there may be some overlap between the work of these two committees, there are also significant differences in their charges and mission. The Advisory Committee on Hereditary and Congenital Disorders that is currently existing in the state focuses on diseases that are present at birth or have a genetic component. most, if not all, of the hereditary and congenital diseases that the current council focuses on are also rare. But there may also be rare diseases that are not congenital or genetic that could be included in the work of this type of a rare disease advisory council under this bill. Additionally, the current council is more oriented towards supporting the state's specific efforts of identifying individuals with hereditary or congenital diseases, whereas this type of rare disease advisory committee would be primarily focused on developing recommendations on how the state can better support individuals who are living with a rare disease. However, I do agree with the feedback that we have received about ensuring collaboration between the two committees. There will be a forthcoming sponsor amendment to add a seat on the Rare Disease Advisory Committee as part of this bill for the chair of the existing Council on Hereditary and Congenital Disorders to also participate in this committee as well. In addition to adding the chair, there will also be an amendment to add a seat for an individual with experience providing care management for individuals with rare diseases. Many individuals with rare diseases receive a variety of services and access to high quality care management that's important for effective care. Overall, this bill will help develop policies to better serve our constituents with rare diseases. Appreciate consideration of a favorable report and happy to turn over to other members of the sponsor panel.
Thank you, Madam Chair, members of the committee. Good afternoon. My name is Felicia Brannon, and I am a patient advocate for persons with rare diseases. And I appreciate the opportunity to testify today in favor of SB 188, as you heard, to create a rare disease advisory committee for the state of Maryland. Rare diseases are a diverse collection, as you heard, of many rare diseases. The latest count in total is somewhere in the range of 7,000 to 10,000 rare disorders, individually impacting a small number of people individually, but as a collective, there are many of us that suffer from rare illnesses. Some of the more commonly known diseases, as you heard, are lupus, MS, sickle cell, et cetera. And it is estimated that 1 in 10 Marylanders are impacted by a rare disorder. A rare disease advisory committee in the state of Maryland would address the various issues, as you heard, of those of us living with rare disorders, and will work with the state legislature to improve public health policies that support our community. Furthermore, the inclusive nature that you heard of the proposed stakeholders for the Rare Disease Committee will work to raise awareness about these illnesses, improve access to care, develop learning strategies, and explore a real holistic approach to address the unmet medical needs of this rare community. I was diagnosed with a very uncommon rare disease, or actually diseases, myositis, interstitial lung disease, and pulmonary arterial hypertension in 2015. The years it took to diagnose my diseases almost took my life, and it ended my career. The passage of SB 188 is a step in the right direction to improve a patient's experience while facing life-changing health challenges. And I hope the passage of this bill will help generations to come.
Hi, thank you for the opportunity to speak to you all today. My name is Mary Morlino, and I've been advocating, volunteering, and working professionally in the rare disease space for over 16 years. I'm a patient manager at Global Genes. I also volunteer with Johns Hopkins as a patient liaison to the Foundation for Sarcoidosis Research. And previously, I worked for the Every Life Foundation for Rare Diseases. In 2021, I co-created Maryland Rare to support to support and advocate for the rare disease community in Maryland, but I need help. We, the Maryland rare disease community, needs help. We need more support, more research, more champions, more action to help improve the lived experience of the Maryland rare disease community. I am both motivated by and frustrated with the lack of information, research, and access to effective medical treatments available for the rare disease community. I'm a rare disease patient. For over 16 years, I've been living with chronic sarcoidosis and a debilitating multi-symptom rare disease of the immune system. In 2007, I was a healthy and active mother of 2 young children. While visiting my sister's family, I unexpectedly collapsed. 3 weeks, 3 hospitals later, no diagnosis, but I was told I was living with heart failure. So they gave me one of these. This is my pacemaker. Still no answer, no diagnosis. Fast forward now, 6 years later, my heart function is rapidly declining. I have a new set of doctors who are looking into what's going wrong with me. And we eventually get a diagnosis. But this was right when I was going through the process of meeting with heart transplant doctors because they didn't think anything was going to help. So when I finally got my diagnosis, within 1 week, I was upgraded to a biventricular pacemaker defibrillator, Exhibit 2. And it saved my life 6 months later. Had it not been for the diagnosis, I would not have gotten the upgrade of the pacemaker defibrillator, and I would have died in my kitchen in front of my daughter. So please support this bill and let's try to help support the rare disease community. Let's work together and efficiently and effectively. Thank you so much.
Good afternoon. For the record, my name is Celinda Carr, and I'm here on behalf of the Coordinating Center. We're a nonprofit that has a 40-year history of coordinating healthcare and community support services for individuals living with disabilities. And I'm the director of a program that provides the care coordination, also known as case management services, to clients in a Maryland Health Choice program called REM. That acronym REM stands for the Rare and Expensive Case Management Program. We currently have 4,100 clients statewide in the REM program, and the day-to-day for our case managers who are licensed nurses and social workers. That includes connecting those clients with rare diagnosis to primary and specialty care providers, perhaps therapists, ensuring that their caregivers feel confident with the complex medical care that they're having to do in the home. Perhaps locating transportation and even finding funding for things that are not covered by their Medicaid plan. A quick story of one of our clients who's now 13 years old. When she was 2 years old, she sustained a fall in a bathtub. She went to the hospital and lo and behold, was diagnosed with a rare disease called Klippel-Feil syndrome. And that's a disorder where 2 or more of the vertebrae in her neck have fused together at birth. The doctors told her family she wouldn't be able to speak and they probably shouldn't expect very much functionally, physically. Fast forward 11 years later, she's still in the REM program. She's thriving as a cheerleader. She does that from her wheelchair. She loves to sing, dance, play with her dog, and arts and crafts. But all that to say that these past 11 years, her family has had the benefit of a case manager working hand in hand with them as they've navigated her rare diagnosis and our complex healthcare system. So the council suggested in this bill would continue to ensure that there's additional state level advocacy for these individuals and their families. Thank you.
Thank you. Senator Kramer.
Thank you, Madam Chair. I just wanted to take a moment and welcome Ms. Brannon to the committee. She is a constituent of mine who has been very focused on this important issue for quite some time. And I know that she will be very pleased when this legislation passes and we take this important step. So just wanted to say welcome to Annapolis and appreciate your being here, as well as you other ladies. Thank you very much for your testimony today. And my thanks to Senator Lamb for this good legislation. Thank you, Madam Chair.
Thank you, Senator. Senator Ellis.
Yeah. Thank you, Madam Chair, and thank you, Senator Lamb, for this great legislation. Ladies, I appreciate your tenacity and sticking with it and to really look out for others in this space. So I think you spoke about REM, rare and expensive. Is it REM?
It is.
So what's
Rare and expensive case management. It's an option within the Health Choice program for a client who has Medicaid and has opted not to be in an MCO, a managed care organization. If they have a REM qualifying diagnosis, they can come into our program, which affords them care coordination benefits.
Okay. And you said that's Medicare?
Medicaid.
Medicaid.
Yes.
And the costs for these rare and expensive diseases are taken care of overall through the?
Absolutely. Under our REM program, it's a fee for service Medicaid program, so they don't require referrals. They're able to see all their specialists without the red tape that you sometimes get through MCOs.
Yeah, so how does someone get the REM designation?
So there's a list of about 300 rare or expensive to treat diagnoses that are available. The program, we are the subcontractor from MDH, and there's a fairly simple application as long as they have that diagnosis and there's supporting documentation for that. There's no cap on the number of clients that can be in our program.
Is sickle cell disease one of those?
It is indeed,
on the list?
yes.
Great. Yeah, thank you. Thank you, Madam Chair.
Thank you. I don't see any additional questions for the sponsor or this panel, so thank you very much. And I concur with my colleague. Thank you for sharing your stories and your testimony.
Thank you.
Is Kristen,
Thank you.
Hi, I'm here.
well, first I had a Kristen Whedon who's here in person.
Okay, so.
And then we'll go to our virtual witnesses. So hopefully you can hang with us just a little while longer. All right, good afternoon.
Who knew we'd have two Kristens in a row? Hi, everyone. My name is Kristen Whedon, and I both live and run a nonprofit organization in Montgomery County, Maryland. I'm here with both a personal and a professional perspective on a rare disease advisory council in Maryland. From a personal perspective, I am a mom and a caregiver of a child with an ultra rare disease called erythropoietic protoporphyria, or EPP for short, which means his name is Brady. He was diagnosed at age 4. He's now 17. And that means it is a phototoxic disease, which causes severe, debilitating, horrific pain on sun exposure. So he's not free to be outside like you or like me on a typical day. So I have been through, or our family has been through diagnosis, through management, through searching for treatments for him and people like him with the porphyrias. With that, I also run the United Porphyrias Association, also based, as I said, in Montgomery County in Bethesda, Maryland. With that organization, I have the privilege of working with patients with all types of porphyria, with healthcare professionals, with industry partners, our pharmaceutical folks who are really working hard on this disease. And we have learned with, as we have mentioned, with over 7,000 rare diseases, that alone we are rare, but together we have a far stronger collective voice to search for faster diagnosis, for more research, for more treatments, and very importantly, access to those treatments once they are FDA approved. So I'm here in support of a rare disease advisory council so that we are able to have a collective voice in the state of Maryland, like the 24 other states around the country. Thank you.
Thank you. I don't see any questions from the committee, so thank you very much for your testimony. We have 3 witnesses, I believe, signed up virtually, so we will go to Kristen Anzelk. Good afternoon. Welcome back.
Thank you. Yes, I'm Kristen, and I was born May 2nd, 1985 in Texas. From my earliest life, I have had medical issues, but no one could ever tell us what was wrong with me. And I was just considered a mystery, which was frustrating. In 1995, we moved from Texas to Maryland. And at age 11, I attended a camp for kids who were born with cleft lips and cleft palates for the first time. And this ended up being a life-changing event for me because it was there that I met Dr. Wolfsberg, who ended up mentioning 2 words to me, which was Kabuki syndrome, which I had never heard of before. But I mean, many of the classic characteristics. And I saw him from age 11 until 2002. From 2002 to 2012, a lot happened for me medically. I had ITP, I received my CVID diagnosis, I had 3 knee surgeries, and I
ended up getting my Kabuki genetically confirmed. And those with Kabuki can't have communication as well as other health issues, including breathing issues. In 2013, I was having a hard time getting a deep breath, but the test told us nothing. So we ended up going to a doctor in November, and he ended up admitting me to the hospital in critical condition. And we were told that they would be starting a medication, but it might not get approved, but eventually it was. In 2015, I attended the first ever Hopkins Research Conference where I met 2 other individuals who had eventually died from Kabuki. And one of the things that I asked for the Rare Disease Advocacy Council to support others like me.
Okay, thank you very much for your testimony. I don't see any questions from the committee. So we'll move on to Anissa Reed. Good afternoon.
Hi, good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Anissa Reed, and I'm a state policy manager for the National Organization for Rare Disorders, or NORD. NORD represents the estimated 1 in 10 Maryland residents who are living with a rare disease. We're very grateful for Senator Lamb for introducing SB 188 and for being a champion for the rare disease community. It can be difficult for state lawmakers to have an in-depth understanding of the rare disease community's needs due to the small patient populations and the variety of rare diseases. This lack of awareness often contributes to the obstacles faced by rare disease patients and their loved ones. And RDAC is an important tool that can help to fill that gap. The council may conduct surveys to better understand common challenges rare disease patients or caregivers face, consult with experts to improve access to quality healthcare, and compile resources related to rare diseases. In many ways, the state of Maryland has been a leader in the rare disease community with nationally recognized healthcare institutions and distinguished healthcare providers with expertise in a variety of rare diseases. Furthermore, the State Advisory Council on Hereditary and Congenital Disorders has done important work for decades, but NORD still believes an RDAC would be a valuable resource in Maryland, particularly on issues related to access to care and treatment for non-inherited or congenital disorders. NORD wants to ensure that both councils are well-resourced, collaborative, and can fulfill their individual mandates to avoid duplication and overlap in their work. To that end, we are supportive of efforts to remove the newborn screening responsibilities from the RDAC and urge consideration of the other recommendations made by knowledgeable healthcare providers in their written testimony that has been submitted to ensure the maximum effectiveness of Maryland's RDAC. Once again, thank you for adding Senate Bill 188 to the committee's agenda and for the opportunity to testify. I urge this committee members to support this important legislation. Thank you.
Thank you very much, and thank you for your testimony. We're going to turn to the final witness on this bill, Geneva Stone. Good afternoon.
Good afternoon. My name is Geneva Stone, and I'm Rob Stone's mom. Rob, 25 years old, an artist and advocate, also has an ultra rare disease, dystonia 16. He's the only reported case in the US among only 20 cases worldwide. Dystonia 16 is so rare that we spent 14 years searching for a diagnosis that is still only available through genome sequencing, a test that analyzes the more than 20,000 protein encoding genes in DNA. Rob also has disabilities, and while Maryland has strong supports for disabled persons, the needs of the rare community do not fully align with the disability community. Our family struggles with prior authorization for life-saving medication, with coverage for the high-dose supplements research has shown are essential to his well-being, with continuity of care, and with access to Medicaid services. Rob was not enrolled in the Rare and Expensive Case Management Program until he was 15 due to wait lists and his lack of a diagnosis. There are 302 qualifying diagnoses for REM, yet there are 7,000 rare diseases, so REM is capable of serving roughly 1% of the rare disease population. Furthermore, of those qualifying diagnoses, 68% end services at the age of 21, so rare adults are often left out in the cold. While I applaud Maryland's progress with newborn screening, it would not have diagnosed Rob. nor would it my dad and sister diagnosed with rare diseases at the ages of 70 and 40, or my hairstylist mother diagnosed at 60. Rare Marylanders need access to genetic sequencing, adult services, experimental treatments, and fair insurance guidelines. We need a rare disease advisory council so we may have a voice in shaping the policies that impact our lives. I urge a favorable report with whatever amendments are necessary. Thank you.
Thank you very much for your testimony. I don't see any questions, so thank you for being here and for sharing your story. And colleagues, that will conclude the hearing on Senate Bill 188. We'll now turn to Senate Bill 200, which is the Health Occupation State Board of Chiropractic Examiners, Disciplinary Actions and Procedures. Welcome back, Senator Lamb.
All right, thank you, Madam Chair, and I ask members of the sponsor panel to please come up as well. Good afternoon, Chair Griffith, members of the committee. For the record, Clarence Lamb, Senator District 12, here to present and introduce Senate Bill 200. This on behalf of the State Board of Chiropractic Examiners. I want to be clear about that. This is a very straightforward bill that adds provisions that exist in statutes for several other health professions to the chiropractic statute. The overall goal of this bill is to ensure that the chiropractic board is able to effectively protect the public. The first part of the bill allows the board to require licensed chiropractors to follow orders of the board. Sometimes a chiropractor receives a complaint that results in the board placing the licensee on probation. The probations often require the provider to complete certain requirements, such as additional training. Under the law, the board does not believe that they have the authority to require a chiropractor to follow a probation order. Several other health boards have a requirement that licensees follow board orders or have similar language to achieve that goal. The second part of the bill makes changes to how appeals of board decisions are handled. Under current law, if the board issues a disciplinary decision, a licensee can appeal that decision in court and ask the court to put the board's decision on hold until the court proceedings end. This allows an unsafe or questionable provider to continue to practice while their appeal works its way through the courts. This bill would prohibit a court from putting a board decision on hold during the period of the appeal. This will ensure that Marylanders are not exposed to unsafe providers just because the provider filed an appeal. This requirement is consistent with statutes governing at least 8 other professions, health professions boards here. Finally, the last part of the bill deals with reinstating a license. Under current law, it is unclear when the board can reinstate or suspend a revoked license. Under the bill, a licensee would need to complete the requirements of their revocation or suspension order, or have the board vote to reinstate them. We have run this bill by the Chiropractic Association. They are supportive of the bill, along with a small amendment to clarify the appeal provisions of the board. The amendment should be in your packet, and there's a letter from the association affirming their support as well. And happy to turn it over to the other members of the sponsor panel this time. Thank you.
Madam Chair, esteemed members of the Finance Committee, good afternoon. My name is Sharon Oliver, and I am the Executive Director of the Chiropractic Board. Thank you for the opportunity to testify in support of Senate Bill 200, a bill that seeks to further the mission of the board and this body, that of protecting the public health, safety, and well-being of the wonderful and deserving citizens of the state of Maryland. As Senator Lamb indicated, the bill has 3 distinctive elements. The first is the provision prohibiting the stay of the final order or of revocation or suspension of an individual who is disciplined for egregious acts or blatant violation of the statute and regulations. It is imperative for the board in its regulatory role to be able to ensure that practitioners who are found to be a threat to the safety and well-being of the public not be allowed to continue the practice of chiropractic during the judicial process. As previously stated, there are several boards that have this provision. Revocation and suspensions are reserved for the worst of worst cases, as most of the time the board attempts to work and settle cases with the practitioner through consent orders and informal discipline. The Administrative Procedures Act allows the board to stay a final decision as is deemed necessary. It is also important that when someone violates a board order that was negotiated, that the board be able to take additional disciplinary action. The third is the goodwill provision, which clearly defines a pathway to re-entry into the workforce. And the board recognizes that individuals may be rehabilitated and consequently be returned to the workforce. We ask for a favorable vote on this bill. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and other committee members. And thank you to Senator Lamb for sponsoring this bill. We greatly appreciate it. My name is Dr. Paul Abosh. I'm the current Vice President of the Maryland Board of Chiropractic Examiners. And in that role, I also serve as the Chair of the Disciplinary Committee. And I'm here to testify in full support of Senate Bill 200, a bill that furthers the mission of our board to protect the public safety, the health, and well-being of the citizens of Maryland. The rationale for our support is simple. Our mandate at the Maryland Board of Chiropractic Examiners is to protect the public from harm that could potentially be done to them by a licensee that is practicing in an unsafe manner. We do this through regulations and laws, and as such, one of our duties is to investigate those licensees who are accused of violating those regulations and laws. If we find a licensee to be guilty of these violations, it is our duty to impose sanctions and restrictions on them. If the violation is serious enough to place the public in direct harm, our regulations allow for us to prevent a licensee from continuing to practice either for a limited period of time or permanently, allowing those that are found guilty to continue to practice while they exercise their judicial right to an appeal would potentially place the public in continued harm, which is what we are mandated to prevent. Thus, I would respectfully request that this committee vote favorably upon this bill. Thank you.
Yes, hi. My name is Dr. Don Hirsch, Madam Chair and Madam Vice Chair and Senator Lamb. Thank you. And the same committee. I am the legislative chair of the Maryland Chiropractic Association, and I'm here to support Senate Bill 200 with an amendment. In studying the bill, the Maryland Chiropractic Association felt that it could use a clarification. So we asked for and worked with both the Board of Examiners and Senator Lamb's office to come up with a clarification, which basically cross-references the Administrative Procedure Act. And there are a number of cases where that could come in very handy, and it's very helpful for the practitioner. Fortunately, there are few and far between chiropractors that will ever face this kind of situation, but we want to make sure that all of the avenues of fairness and the protection of the public are honored. Thank you very much. I appreciate your support.
Thank you. Senator Ellis.
Thank you, Madam Chair, and thank you, Senator Lamb, for this bill. Quick question, as far as the order of a board may not be stayed pending judicial review. So is it my understanding that if someone is suspended, for instance, they request a stay from some level of the court system? And so is this bill saying that a judge cannot issue a stay? Is that the intent to tell the judiciary?
That is the intent, and the reason for that is that, let me give you some history. The chiropractic board and the massage therapy boards were once one board, and in 2016, the boards were split. We share a staff, and we have seen a number of cases between either of the boards where you may have an individual who has committed some serious egregious offenses. Example, sexual misconduct, crossing unprofessional professional boundaries. And we have had individuals who have been sanctioned by the board and have gone to the court and asked them to stay the order while it's going through the judicial review process. Those cases are typically very detrimental to the public. And in that case, we want to ensure that because the board understands these boundary issues, that a judge who may not have all the facts in front of him or her at that point, not be allowed to stay the board's order when we are trying to protect the public.
Yeah, so have the Attorney General say that's a constitutional thing, we can tell the judge, take away that discretion from a judge. If the case ends up in their courtroom, that seems kind of out there to me, so.
Well, we do have other boards that have that provision. So we are following the same guidelines that the other boards have. And when you look at the population that many of these boards are protecting, many of them are in a vulnerable position. And we want to ensure that they are protected.
And,
So-
and I'm sorry, I didn't mean to interrupt.
No, go ahead.
As Dr. Hirsch had said before, the number of times that a licensee gets to this point where the board is faced with no other choice but to suspend or revoke their license, those are rare. There's many steps in the disciplinary process before it even gets to that point. And if it does get to a point, it gets to a point because there is a serious risk of imminent public harm because of things like sexual misconduct, boundary issues. And that is why, we are in full support of the Maryland Chiropractic Association's proposed amendment, which would give our licensing board the authority ourselves to stay our own order if we feel is appropriate for the guilty party.
Okay.
It's, really a patient safety kind of provision in there. And to Ms. Oliver's point, that these two the Massage Therapy Board and the Board of Chiropractic Examiners were once together. They're split apart. And I think you're actually sponsoring a bill for the massage therapist that touches on very identical language as well. So this kind of mirrors that for the Chiropractic Board.
Yeah. Okay, thank you.
You're welcome.
Thank you very much. I don't see any additional questions from the committee. So thank you all for your testimony and for hanging out with Senate Finance today. That
Our
concludes,
pleasure. Thank you.
that concludes the hearing on Senate Bill 200. Colleagues, will turn to our final bill of the day, which is Senate Bill 232. Senator Beidle, and she is coming forward to present the Health Occupations Licensed Athletic Trainers Dry Needling Approval.
Madam Chair, can I bring my panel? I guess I am.
I'd say yes. Let's bring your panel up.
Thank you. Thank you, Madam Chair and Madam Vice Chair and members of the committee. And I apologize. I think we have 17 witnesses today. So I'm going to ask my witnesses to please stay within their 2 minutes so we can all finish up. But thank you again, Madam Chair. So for the record, Pam Beidle, District 32. Thank you for the opportunity to present Senate Bill 232, Licensed Athletic Trainers Dry Needling Approval. This bill passed the Senate last year with 45 votes. The House didn't choose to take a vote. Right now, dry needling can be performed by acupuncturists, chiropractors, and physical therapists. And some of the people in this committee were in EHE last year and heard this bill and voted for this bill. So this is not the first time that everyone has heard the bill. It's an important bill for athletic trainers, for athletes, for educational institutions in the state. It establishes a licensing process for athletic trainers to perform dry needling. Now, again, there are other organizations that do this, but this increases the scope of practice for athletic trainers. And I know that's always a little touchy when we try to expand the scope of practice. This is allowed for athletic trainers in 28 other states and Washington, D.C. So this is not new. It might be new for Maryland, but it's in the majority of other states in the country. You are going to hear opposing testimony from the acupuncturists. That will be the only group that you hear opposition from. We have a couple of issues to address with the Physicians Board, which we addressed last year's concerns. They have brought some new concerns this year that we will address, but I asked for the committee to consider giving this important change in scope of practice to our athletic trainers. As I said, in 29 other jurisdictions in the country, they're allowed to perform this. It's very important for the athletes that are injured. It can give them very quick relief and help them on the road to recovery. So I ask for your favorable support. Thank you, Madam Chair.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Jane Miraglia, and I'm the Maryland Athletic Trainers Government Affairs Committee Chair. Thank you, Senator Bidle, for sponsoring this again. So dry needling is based on Western medicine, anatomical-based medicine, and it's already defined in COMAR. In the definition of dry needling already in COMAR and in our bill, it specifically states dry needling is not performed for the purpose of acupuncture. Dry needling is especially helpful for trigger points and muscles that cannot be palpated by hand. The deactivation of trigger points can bring immediate relief of symptoms not attained by any other treatment. As we've stated, dry needling is different than acupuncture. Acupuncture is based in Eastern medicine. And in fact, COMAR already defines acupuncture as different skills, again, than dry needling in COMAR. As Senator Bidle said, Senate Bill 232 is the same dry needling bill that passed the Senate last year. It has the same strict qualifications as physical therapist with the required advanced training, competencies test, and supervised hand-on experience. We can do this in 28 other states and in DC. We worked with the Maryland Board of Physicians last year to handle their requests for administrative stuff. Today is the first day we've seen that, but we are already in the process of answering their questions. And in addition to the Maryland Board of Physicians, each athletic trainer who wants to dry needle has to have their supervising physician sign off that they can dry needle. So our physician has to be on board with it as well. Hortz et al. Found that athletic trainers and physical therapists have very similar educational backgrounds, which provide the necessary foundation to become dry needling certified. This is not surprising given that there are already so many shared therapeutic modalities between healthcare professionals, including dry needling. An additional study on the adverse events of dry needling found that less than 0.1% of dry needling treatments resulted in a major adverse event. And none of these events required emergency care after these dry needling sessions. I encourage you to ask the question to the athletic trainers testifying today who are already certified to dry needle in other states or who are here as physical therapists as well. Thank you for your time and please vote favorably for Senate Bill 232.
Hello, my name is Colin Francis, and I am the Assistant Athletic Trainer at the Baltimore Ravens and the Executive Director of the nonprofit organization, the Baltimore Area Sports Health Initiative. I'm from PG County, and I live in Baltimore City now. Up until recent events in the National Football League, most people didn't even know what an athletic trainer was. My job is to do every single thing I can to help the Ravens players stay safe and return from injury as fast and as strong as possible. After the recognition and evaluation of an injury, we are responsible for the acute management and long-term care of the athlete. All the treatment and rehabilitation needed is done in my office. Unfortunately, in this state, I can't do everything I have been certified in to help the athletes return to play. Adding dry needling to my practice will allow me to use an advanced skill that I have been formally trained in to help the Ravens athletes. Before moving to Maryland, I served as the head football athletic trainer and director of rehab at Indiana University. My dry needling certification was hosted by IU, and for the entire course, lab, and lecture, I was trained alongside athletic trainers, physical therapists, and chiropractors. For 2 years, I was able to use this technique with the football players. IU had a staff of maybe about 15 athletic trainers, and in the 2 years I worked in Indiana, after my certification, there was not one adverse reaction to the treatment for any of the student athletes. Most of the patients described the treatment as a true game changer when it came to their injuries, a specific modality that allowed them to perform to their maximum potential. The anatomical basis of the skill really allows an athletic trainer to use their knowledge to its full capacity. While working at the college level in Indiana, I found great success in patient outcomes. I was excited and eager to use this skill with players when I moved to Baltimore. I pride myself in being innovative and creative when working with athletes. Athletic trainers build relationships based on trust with our patients. We treat their whole body and their mind. With a limited scope of practice in Maryland, I'm not able to do everything I'm certified and trained in. That's why I ask for your support of Senate Bill 232 and welcome any further discussion. Thank you.
Thank you. My name is Wes Robinson, and I speak to you today as perhaps the only athletic trainer in Maryland that is allowed to perform dry needling. I'm able to do that because I'm also a licensed physical therapist. Being dual credentialed for over 20 years, I can say without reservation that athletic trainers are clearly educated to a level to take the advanced certification course and perform dry needling. My colleagues have been sidelined by restrictive legislation, and therefore their patients are being denied a productive treatment opportunity. I completed the appropriate dry needling training in 2014. For the past 9 years, I have safely performed dry needling on countless patients without any adverse effects. These advanced certification courses are exhaustive, covering all aspects of the treatment and any possible negative outcomes. The course teaches you how to deal with and respond to any adverse events that may occur, and more importantly, how to avoid them in the first place. Allowing athletic trainers to perform dry needling would be consistent with 28 other states in the District of Columbia and follow in accordance with the training standards set forth by several educational outlets that train healthcare professionals in the modality of dry needling. Why would these businesses risk educating an individual in an invasive technique that the individual was not qualified to perform the task? Doing so would be a perilous liability risk for these corporations. Yet consistently, we see these businesses offering the exact same dry needling certification course to athletic trainers, to physical therapists, and chiropractors alike. Dry needling is an advanced technique that requires advanced training. That training is required by this legislation, and it should not be restricted to only certain healthcare practitioners. Why in the state of Maryland is it okay for a physical therapist to perform dry needling and an athletic trainer cannot? Both are licensed healthcare providers. Both have completed the prerequisite educational requirements to take the course. Both can complete that course and learn the technique. Why place an arbitrary limit on the patient population in our state that can receive this safe and effective modality? I urge you to support Senate Bill 232 so we can increase the patient access of Marylanders being able to receive dry needling. Thank you.
Good afternoon. My name is Adrian Dixon. I'm the head athletic trainer for the Baltimore Ravens Football Club. I'm here today in support of passage of Senate Bill 232. I believe as healthcare professionals, we have a duty to serve our patients in a manner that seeks to provide the best healthcare possible. I'm speaking about the patient populations that I serve, particularly as professional athletes. I strongly believe as an athletic trainer, I should have the ability to provide this method of treatment to our athletes. I happen to be a physical therapist as well, and legally, this is the only way I'm able to provide this treatment currently. In the previous state I practiced in, which was Tennessee, dry needling was also not within the scope of practice for athletic trainers. This put an undue burden on me personally, as I was the only dual credential professional on staff, which is what an athletic trainer would have to be to administer that treatment. It can become extremely demanding and inefficient for our treatments. Teams seek to hire athletic trainers as demonstratively, it's clear now that we're the most suited and equipped to work in the athletic setting. If you need proof of this, we all witnessed the Buffalo Bills player a few weeks ago. I also worked in the state of Texas, where athletic trainers have the ability to provide dry needling to their athlete. It truly bothers me, that competitive drive within me, to know that the Dallas Cowboys and the Houston Texans can be more efficient and effective in their treatments with athletes, which in theory gives them a competitive advantage. I support the passage of this bill 100% because I believe athletic trainers in the state of Maryland are well suited to be able to provide this treatment safely and effectively. If there is doubt, I'd point you to the 28 other states and DC who already allow athletic trainers to dry needle. Additionally, I have 8 years of dry needling experience with no adverse effects. It's time to advance the scope of practice for athletic trainers in this state. This is more than appropriate because as a medical professional would attest, any of you would attest, as the research and knowledge evolve, the practice should evolve. And in my opinion, evolution is long overdue. So I respectfully request a favorable vote on Senate Bill 232.
Thank you. Senator Kramer.
Thank you, Madam Chair, and to the two gentlemen from the Ravens, just one important question. Had you all had the capacity to do this, would Lamar have been in the playoffs? That's what I want to know. That's because if you say yes, I'm like all in.
Just say yes.
Well, I'd have to convince him that it's necessary for him to get him back out there. So.
All righty then. Thank you. Thank you.
Thank you. Senator Reedy.
First of all, there is somebody on this committee who is a Dallas Cowboy fan, so hopefully they will not allow, I'm not going to name names, but hopefully they won't allow that. I hope they won't allow that to impact their decisions on this. It's not me. A serious question. We're going to hear opposition from acupuncturists, and I'm looking at the testimony and trying to understand the issue, even though I did vote for the bill last year and I'm supportive. What is it that dry needling does? I mean, what is it that they do? It's not the same thing. It's the same. It's some of the same ideas, but it's not. I know one of the witnesses already talked a little bit, but yeah, I'd love to just know, because there's room for both here, right? This is not an exclusionary thing.
I will say that I work at the University of Maryland Orthopedic Association, and we have a physical therapy clinic. We have orthopedic surgeons, we have PAs, we have DOs, and we also have acupuncture clinic at the other end of the same floor, same building, same group. So our physicians refer to both. They send their patients to me for dry needling. They send some patients that are appropriate for a different modality down to the acupuncturist.
I'll give you a kind of a real life experience. So a few years ago, my husband was bowling and he tore a hamstring and it was very painful. And for weeks, he had physical therapy, weeks. The physical therapist there was licensed to do dry needling and they switched his therapy to dry needling. And within two visits, he was finally out of pain and able to walk again. So it made a huge difference in his recovery. And just seeing that's why I'm sponsoring the bill. I know how important it can be to help athletes get well again.
Because it can infuse it into the physical therapy and the training as opposed to you go to acupuncturist for other needs, correct? I mean, is that fair to say?
Well, the science and the medicine is a little different. So acupuncture is traditional Chinese medicine. They deal in energy systems and really great modality for people who experience pain and see them and have relief. Dry needling is anatomically based and used more with the line of pull of the muscles and the anatomical basis of the muscle fibers and how the body is built, not so much energy systems.
Okay, thank you. Thank you, Madam Chair.
Thank you very much. I don't see any additional questions for the sponsor panel. So thank you very much for your testimony. I know it's been a very long day, so thank you for hanging with Senate Finance. We'll call forward Bill Pitcher.
Madam Chair, I know some of our people who had signed up virtually to testify got pulled out to practices, so they will not be on. So we will be less than 17.
Okay, if only I knew which ones.
Oh, Caroline Sebens is the only one who's notified me so far, but I believe there might be others.
Fair enough. Thank you. Good afternoon, Mr. Pitcher.
Thank you, Madam Chairman, members of the committee. Bill Pitcher here on behalf of the Maryland Athletic Trainers Association. Jane is technically my client on this. And the Ravens actually came to the association last year requesting that we work on this issue. And that's where the bill actually comes from because of the fact that, as you heard, they're athletic trainers who were certified and trained in other states came here and now they couldn't do it. And I'm hoping that Lamar will avail himself of it, Senator. I'm here to just answer any questions that are still pending as the association could answer them. And to just tie up one loose end here. 12 years ago, the Attorney General's issued an opinion to the committee dealing with this very same issue as it related to physical therapists. And in that opinion, they made it very clear, which is now reflected in COMAR regulations, that dry needling is not acupuncture. It's similar. It has some overlap. And the Attorney General's opinion, and I'll just read one sentence to you, made it very clear. It says the authority to use acupuncture needles for therapeutic purposes is not necessarily reserved to the licensed acupuncturists. State law recognizes the scope of practice of healthcare professions may overlap and confers extensive discretion on the licensing boards. So COMAR reflects that opinion. The Attorney General has not reversed that opinion. And when you hear from our opponents here that, no, they're asking to do acupuncture, that is just not true. They want a limited scope to use this modality in their scope of practice. Let me just, if I might, Madam Chairman, urge you to ask one question in your own mind as you go through the hearings of the opponents. Are we here to pick winners and losers as opposed to, acupuncturists or athletic trainers? No. We're here, you are here to protect the citizens of the state and give them the best health care they can get. And I believe that this bill will help them advance that. Thank you.
Thank you. All right, I don't see any questions from the committee, so we're going to move to Roshan Burrell.
Yes, hi.
Callie Gumand, Denise Tyson, who've signed up in opposition to the bill. Good afternoon.
Good afternoon.
Thank you for your patience.
Thank you. All right. Who goes first? You may go first. Doesn't matter to me. All right. Good afternoon or good evening as we're getting into the evening. I'm Dr. Rashawn Burrell. I'm a licensed acupuncturist. I have a doctorate in acupuncture and oriental medicine. I've been practicing for over 11 years and this is very special to my heart, this medicine. It is helped so many people. So I'm just going to read here. So I've been acupuncture for 11 years, treated many sorts of conditions, mostly pain. I have many of my patients come to me over the years after seeing someone who has done dry needling and tell me that it really hurt and it wasn't that effective, to which I have to explain those providers have not been trained to do acupuncture. I mean, dry needling. So the results are usually not great. Acupuncture is extremely helpful and works well with other treatments when done by trained acupuncturists. Those who understand the nuances of the medicine. I understand that this is not about traditional Chinese medicine, but about needling, and that is the problem. Needling is acupuncture, and acupuncture is traditional Chinese medicine. When you put a needle in someone, you are affecting their body's energy, whether it's in a muscle mass or not, you are affecting their energy, and you are doing an essentials traditional Chinese medicine. So to separate dry needling, the act, from what acupuncture and traditional Chinese medicine is, you cannot, because you cannot touch the body and not have an effect on it, whether it be with a needle or with your hand. So when you are putting a needle into somebody, which is an invasive procedure, you should have proper training to do that. And that's where my thing comes to. Dry needling is an advanced and invasive procedure. And as the gentleman said earlier, the Attorney General stated in here that yes, there's a difference between it, but there isn't in my book. But he also stated that you guys and any process should consider the standards and education and training that is presumably would be at least as strict as those set by legislators for the physicians and the acupuncturists who use these similar therapeutic purposes.
Good evening, Madam Chairwoman and Vice Chair and the committee. I'm Dr. Denise Tyson, and I am president of the Maryland Acupuncture Society. I have a doctorate in acupuncture and oriental medicine. I'm here to represent the Maryland acupuncturists to ask you to not vote in favor of Senate Bill 232. I'd like to go back to the talk about dry needling and what that's about. Dry needling is rooted in acupuncture. There's a lot of research, including the doctor that brought it forth, Dr. Travell. And we have tons of Western research about acupuncture that acupuncture is based in science. It modulates fluid physiology, it restores blood flow, innervates the nerves and fascia, stimulates change and release of immunological modulators, neurotransmitters, hormones, and we have different levels to acupuncture. You have the localized, which is dry needling, it's called ashi. And that is what the concept of dry needling was based on in the first place. And then you have the systemic part of what they're talking about with dealing with the neurological response. That is acupuncture. And then I also heard from the athletic trainers where they referred to the mind and the body. And if you're needling to take effect on the mind and the body, you're practicing acupuncture. So what I want to say is that, you know, there's a lot of focus on the typical adverse reactions, but let me tell you, there are other adverse actions. You can metastasize cancer, you can drive a superficial illness deep into the core, disrupt an emotional situation. You can work on an athlete and put them in a worse state than when they began because you don't know the medicine. Thank you.
Good evening. Thank you, Madam Chairwoman and the committee. I'm Dr. Callie Guymond. I am the founder of AcuCongress, but up until a year ago, I was also a Maryland licensed acupuncturist. I studied right up the road in Columbia at the Maryland University of Integrative Health. It was one of our first accredited institutions on the East Coast and in this nation. That program shut down in July after 40 years? Because of actions such as this. So I wanted to give you some analysis on the impact of what regulatory and legislative actions are doing to your licensed acupuncturist, who, by the way, are only licensed acupuncturists because at the time that we got a statute, no one would entertain licensing anything with the name Chinese in it. And no one would entertain licensing them as traditional Asian medicine practitioners. And so they settled for the modality that they use, which is acupuncture. And now we are licensed acupuncturists. So we agree that they are not doing acupuncture the way that we do it. And in fact, I spoke to Colin and he said, you know, I'm not doing traditional Chinese medicine. I agree with that. We agree with that. But perhaps they should learn some of it if they are going to be putting needles in bodies that have points that actually do have physiological, biological, medical responses that can result, if not done properly, in a pneumothorax. Now, if you needle the shoulder right here, shoulder pain is a part of injury, you are going to be needling directly over the lung. And it is not listed in the bill as a contraindication. They list bruising, swelling. They don't list that they could collapse a lung and end in a fatality. And either they knew the gravity of the situation and they didn't list it, or worse, they didn't know it. The science isn't different. We think we should just step away from the table now and try again with them to work together on this. Thank you.
Thank you. I don't see any questions from the committee, so thank you very much for your testimony and thank you for waiting throughout the day. And yes, thank you for being here. We're going to turn to some virtual witnesses on the bill, starting with Jean Perez.
Good afternoon, everyone. Good evening. Yes, my name is Jean Perez. I'm the Director of Student Health and Wellness at Goucher College. I'm also the President of the Maryland Athletic Trainers Association. I would urge your support of Senate Bill 232 to allow athletic trainers in the state of Maryland to practice to the full extent of our certification, education, and training. It will allow us to provide better patient care for our patients, and it will also allow us to recruit more athletic trainers to the state of Maryland and just better serve our athletic population in the state. Thank you.
Well, thank you. I don't see any, you've got big smiles. I don't see any questions from the committee. We'll move to our next witness, which is Stephanie Guzzo. I think.
Hi, good evening. My name is Stephanie Guzzo. Thank you so much for letting me and so many others testify virtually. Greatly appreciate it. I'm an athletic trainer, and I am here in favor of athletic trainers being able to dry needle. I used to work in a neurology office, and we would see patients of a variety of different different disabilities. And whether it was in that setting or athletic trainers working in clinics or with athletes or a variety of different patients, this is something that we have been wanting to use, been wanting to do for quite some time. And it's also not something that every athletic trainer can do or will do once. It's something that we will do once you get certified. You have to have that certification. But just being able to do it and being able to practice like so many of our other athletic trainers in other states. So please support the Senate Bill 232. And again, thank you for your time. And I see for the remainder of my time.
Thank you. Seeing no questions, just thank you very much for your testimony and for hanging around. We're going to turn to Rachel Moore.
Hi, good evening. Hi, how are you? Good evening, everyone. Madam Chair, Madam Vice Chair, thank you guys, and the rest of the Senate committee. Thank you for hearing our support in Senate Bill 232. I am a secondary school athletic trainer. I've been an athletic trainer for about 20 years. And I'm here to support Senate Bill 232 to show you that athletic trainers are a multidisciplinary athletic healthcare professional. We are the frontline healthcare providers for all of our athletes and athletic populations throughout the state of Maryland. Adding dry needling to one of our tools is another tool that we may utilize as athletic trainers to enhance our well-being of and outcomes of all of our athletes. It's also required of a specialized certification that not just everyone can do. So we are hoping that, again, it's utilized in the correct way with the right thing. We have 28 other states, including Washington, D.C., that are already allowing athletic trainers to do this service. And Maryland should be one of the frontline places. As a secondary school athletic trainer, we are in a shortage of athletic trainers right now, and we have athletic trainers actually leaving the state of Maryland to go to other states so they are able to pursue their abilities and capabilities of providing this service. And again, it is a need. We need athletic trainers in this state. There's a huge shortage, and passing this bill would not only enhance the care and well-being of all athletic and active Marylanders in the United States, or Marylanders in our state, but also help get more athletic trainers into our state to provide support for all of our patients. I cede the rest of my time. Thank you all for hearing me.
Thank you. We'll take all 5 of those seconds
Sorry.
back. Thank you very much. I don't see any questions for you. Thank you so much for your testimony. We're going to hear from Brian Kaplan. Good afternoon, good evening.
Good evening. I appreciate your time. My name is Brian Kaplan. I'm a regional director and a physical therapist with MedStar Health. I oversee 7 sites in the Baltimore region for MedStar Health, and I've been doing dry needling for approximately 6 years now. I work hand in hand collectively with athletic trainers in a variety of settings, from the professional to the high school to the collegiate. I can tell you from an education standpoint, from a training standpoint, from a response standpoint, this is a game changer for patients, for anybody. It's 2023, right? So healthcare is evolving. It's always changing. And dry needling is an evidence-based practice that moving forward is only going to make patient care better. The infighting that occurs between various settings in healthcare is just quite unsettling to me. I appreciate the opposition and their discussion, but in the same sense, as a physical therapist and as athletic trainers that I work with, I can tell you the level of education that we have is peerless. 4 years undergraduate degree, 3 to 4 years master's or doctorate level degree, anatomy, physiology, biology, histology, you name it, right? And so we're trained effectively. Needling right now in the state of Maryland for physical therapy is 80 hours of continuing education. But that's not even part of it. I mean, so much of it is the knowledge base of the anatomy and the physiology, to the point that was made about a pneumothorax. Of course, I understand anatomy. I understand what I'm doing, how I'm directing the needle, the purpose of it. With my final 20 seconds, I can tell you that there was a research study that was done where they used cortisone, lidocaine, and nothing. And all the patients had positive outcomes. And the common denominator was the needle. And that's where dry needling comes from. It's not that we're trying to be acupuncturists or saying that we do acupuncture, but we just want what's best for the patient. And collectively, we should do that.
Thank you very much. I don't see any questions, so thank you very much for your testimony. We're going to now turn to Brandy Armijo, who signed up in opposition to the bill. Good evening. If you can unmute. There you go.
So here we go. Okay. Good evening, Madam Chair, committee members. My name is Dr. Brandy Armijo. I'm a professional member and the board chair of the Maryland Acupuncture Board. I'm here before you to oppose this Senate Bill 232. I've been an acupuncturist for 13 years and on the board for 5 years. The acupuncture, the physical therapy, and the chiropractic board all are opposed to this bill and are motivated due to our obligations to public safety. Physicians, dentists, veterinarians all trained an additional 300 hours before inserting needles used for dry needling. If these highly trained health professionals willingly train more than 80 hours to obtain a certification before inserting needles in a patient. Why would another health profession with less directly relevant training believe 80 hours is sufficient? We oppose the Senate Bill 232 and request unfavorable vote. Thank you.
Thank you for your testimony. We do have one witness I missed who's in the virtual space in support of the bill, so we'll go to Brian Perez.
Madam Chairman, he messaged me as well. He is at practice. He will not apologize.
Well, he's there.
Okay, well, I guess he figured it out. I apologize.
Yes, no problem. Good evening, Brian. You can proceed. You've got to unmute for us.
Can you hear me now, folks?
Yep.
Thank you so much. My name is Brian Perez. I'm a certified athletic trainer in the state of Maryland, and I'm coming to you today in support of SB 232. As you've heard by multiple practitioners and healthcare providers, physical therapists, and athletic trainers alike, I firmly believe that passage of this will help athletic trainers and will also help our patients that we treat in the state of Maryland. As an athletic trainer, I'm viewing this more from a position of someone who is actively recruiting and hiring athletic trainers in this state, and knowing that if we have the ability to accept that athletic trainers can practice dry needling in this state, that will open up jobs. That will help our colleges and universities with master's level athletic training programs be able to include that as part of their master's of education program. We are in a state at this time where we're looking to hire athletic trainers and bring them into the state, and I think this would help that. As was stated before, this is a secondary certification that requires significant training, significant coursework, and significant practice before being allowed to completely use this skill set. So I believe in, I believe, and I thank the physical therapists and other athletic trainers who have come forward in supporting this bill, and I hope that everyone will support this bill. So I would like you to vote in favor of it. And I thank you very much for your time, and succeed the rest of my time.
Thank you. Thank you for your testimony. We're going to move to our final witness on the bill signed up in opposition. Diane Gioso?
That's correct.
Okay.
Thank you.
Good evening.
Good evening, and thank you for hearing my testimony tonight. My name is Diane Gioso. I'm a licensed acupuncturist in the state of Maryland for the past 21 years. I'm coming to you from my clinic tonight to strongly oppose the bill in front of you. I'm testifying not only as a clinician, but as an educator of Chinese medicine, a professor of Chinese medicine at Taoist Traditions College in North Carolina. I've also taught at MUIH, the local university, as well as 2 other universities in this country. I'm an educator to the profession nationally and internationally as well. I'm also the mother of a student athlete in private school here in Maryland. So I have a lot of stakes in the game, and mainly safety for our community and our children and our medically vulnerable patients. Many people have talked about safety in terms of dry needling for our community in Maryland, and I agree. Dry needling can cause injuries, as can acupuncture. However, dry needling can cause pneumothorax, nerve damage. It's been career-ending for more than one athlete, as well as a dancer in North Carolina. Regularly in my practice, I see excessive bruising and exacerbation of pain from the technique itself. It uses the tools of acupuncture, the logic of acupuncture, the techniques of acupuncture, as well as the point location of acupuncture. As a historian of the medicine, I would argue also that the technique and mapping of dermatomes as it's understood within their medicine goes back, it's not originated, but also it returns to a third century physician, Huatou, who has wrote extensively on the subject, and it can be traced back to there, as well as other Chinese medical historical figures, as well as contemporary practitioners. And as a teacher, I would consider dry needling a complete cultural appropriation. And its piecemeal practice is also offensive to the profession. They also ignore prohibition to points and cautions that we do within our profession, especially points for pregnant women, as well as people who have cancer. I can tell you a lot of horror stories around my oncology patients I've seen in my practice. And there are 80 hours is basically what we have to do in terms of demonstrating our competency in testing. 3,500 hours didactic, 500 clinically supervised hours. MDs have to have over 300 hours in this state in order to practice.
Yep, gonna have to wrap it up, but thank you very much for your testimony. Let me thank the members and all of the witnesses. This was a long day and we're just getting warmed up. So that is going to conclude the hearing on Senate Bill 232 and conclude our bill hearings for today. Thank you all very much. This meeting's adjourned.